Maternal Morbidity and Mortality 2023. Pakistan is a developing country, and in spite of all our efforts, we are unable to meet the target of maternal mortality. That's why we have gathered here today to speculate the role of multidisciplinary approach in reducing the maternal morbidity and mortality. I request worthy Vice Chancellor, Professor Dr. Mahmood Iyaz, who has guided us in every aspect of this conference, from deciding the theme of the conference till the practical conduction of the conference, to grant us permission to open the conference formally. Thank you, sir. Beginning with the holy name of Allah, I call upon Dr. Aisha Tasneem to say a few verses from Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إذا جاء نصر الله والفتح ورأيت الناس يدخلون في دين الله أفواجا فسبح بحمد ربك واستغفر इन्नहु कान तव्वाबा। अल्लाह के नाम से शुरू जो निहायत मेहरबान और रहमत वाला है। जब अल्लाह की मदद और फतह आए और तुम देखो कि लोग फ़ौज दर फ़ौज दीन में दाखिल हो रहे हैं, तो अल्लाह के रब की सना करो और अल्लाह की पाकी बयान करो और उससे बख्शिश चाहो, बेशक वो बहुत तौबा कबूल करने वाला है। सदक़ल्लाहुल अज़ीम।
Jazakallah. I request all my seniors and colleagues to kindly stand on their seats in the honor of National Anthem of Pakistan. Thank you. Kindly be seated. I request worthy Vice Chancellor, Professor Dr. Mahmood Ijaz, our Chief Organizer, Professor Dr. Mehrunissa, and Honorable Guest, Professor Dr. Taiba Wasim, to kindly join us on the stage. Madam, please. Madam, फिर अब आपका है इसका बैच। I request Professor Dr. Mehrunissa, Head of Department Unit 4, Ops and Gynae, King Edward Medical University, who is the backbone of this conference and who worked day and night for this conference, to kindly come on the dais for her welcome address.
Thank you, Dr. Khadija. Bismillahir Rahmanir Rahim. Assalamu alaikum. Dear audience, इसमें भी खोल दो ना, इसमें किधर है 21st वाली किस चलो ठीक है. I am Professor Dr. Mehrun Nisa, Head of Department of Obstetrics and Gynecology, Lady Aitchison Hospital. Warm welcome on behalf of Department of Obstetrics and Gynecology to all the honorable guests to this conference, which is organized under the supervision of our worthy Vice Chancellor, King Edward Medical University, Professor Dr. Mahmood Ayaz, who is the main power behind all academic activities in King Edward Medical University. Excellence in academia is the goal set by our Vice Chancellor, and this conference is one of the steps to achieve this goal. Our ex-dean, Obs Gynae, King Edward Medical University, Professor Aisha Malik supervised and supported us to organize this workshop, this conference, and inshallah hope to continue our working with the same spirit with existing senior staff, Professor Dr. Uzma Hussain, Professor Dr. Kiran Khurshid, Professor Amna Yusuf, and our Associate Professor Dr. Khadija, Dr. Abda, Dr. Madiha, Dr. Sumaira, and the rest of the Obs Gynae staff, King Edward Medical University. Theme of the conference is Reducing Maternal Mortality, Role of Multidisciplinary Team, which are mechanisms of organizing and coordinating healthcare services to meet the needs, special needs of the patients. Global perspectives, maternal mortality rate according to WHO 2017, MMR was 462 over 100,000 live births in underdeveloping world and just 4 in developed world. And the aim of sustained development goal is to reduce this to 70 per 100,000 live births till 2030 in underdeveloping countries. The situation in Pakistan is, in 2017, MMR was 276, which reduced to 186 per 100,000 live births in 2020. In the 2022, the data in Lady Aitchison Hospital, our record shows the MMR was 33.3 per 100,000 live births, and the main causes were eclampsia and its complications, massive obstetric hemorrhage, and sepsis. Established in 1887, Lady Aitchison Hospital is a 200-bedded hospital, but it shares workload almost equal to the rest of the public sector hospitals in Lahore and Punjab. In 2022, the patient admitted were 40% were unbooked and 50% were high risk, all managed in collaboration with a dedicated multidisciplinary team from Mayo Hospital, Lahore. Regarding global perspective, we have our international speaker, Professor Dr. Gohar Wajid on board, and Professor Azizun Nisa, President, Society of Obs Gynae, Pakistan. She is also on board. Agenda of this conference is saving mothers' life by taking ownership of critically sick mothers due to obstetric emergencies by multidisciplinary team. And our data 2022 in Lady Aitchison shows that in majority of the high-risk patients, we involve anesthetists, ICU specialists, physicians, and Professor Zara and her team from Mayo Hospital, Dr. Kashif and his team from Lady Aitchison Hospital are on board today, and Professor Arshad Taki, our speaker as anesthetist, is with us. From medical floor, Professor Imran, Professor Adil, Professor Shandana, Professor Israel Haktoor are on board, and our international speaker, Professor Tabinda Dougal, President KEMCA UK, will join us as physician. From surgical floor, our colleagues, Professor Asghar Deki, Professor Abrar Ashraf, Professor Uzair, Professor Amir Afzal, they are all with us, and Professor Askar Naki will join us as surgeon. And sepsis and septic shock are important cause of maternal deaths. And Professor Dr. Sultan Faisal Sultan, he is with us to address this issue. Massive obstetric hemorrhage is a big, challenge to manage. Dr. Mizna, Associate Professor from Hematology, King Edward Medical University, is with us to address this issue. Professor Majbi from Radiology, Professor Fawad from Urology, Professor Anis from Nephrology, they are all on board. Ambulance services are very important to timely shift the patients. And from administrative floor, we have our medical superintendent, Mayo Hospital and Lady Acheson Hospital, Dr. Munair Ahmed Malik, and Chief Executive Mayo Hospital, Professor Haroon Hamid is also on board. Our medical student undergraduate, they are soon join us, they're taking their class. They are, a big working force in managing our emergencies during their maternity duties. They draw blood samples and especially help in collecting blood. And blood bank also has, a lot of workload while we are managing obstetric hemorrhage. Finally, midwife and nurses, they are an important part of this multidisciplinary team, and they are also on board and they will soon join us. Meet our multidisciplinary team. Our record in Lady Acheson shows the surgeon and the urologist who untimely and odd hours of the day and night attended our patients, Dr. Ghazanfar, Dr. Ahmed, Dr. Irfan Salim, Dr. Usman, Dr. Abira, Dr. Shehzad, and Dr. Ghaus. Thank you so much. We are really, very thankful to all these multidisciplinary team members who visit and manage our patients and save the lives of the mother. And finally, research and publications are the only way forward, and our future for our young researcher, I will say, Zara nam ho to ye matti bahut zarhez hai Saki. I invite young researcher to research in the area of how to reduce maternal mortality in Pakistan. In this regard, we have a session on research papers in the adjacent hall, oral presentation, and poster presentation in the gallery. As medical specialists, we keep a hawk eye on the system, what is good, what are the gaps, and how to fill these gaps. And as obstetricians, nothing is more important to us than to provide the best maternal health services and reduce maternal mortality. And this conference is one of the steps in this regard. Once again, warm welcome to all the honorable guests, especially our Vice Chancellor, our Professor Faisal Sultan, Professor Shamsa, Professor Uzma, Professor Kiran, Professor Askar Naki, Professor Abrar Ashraf, Professor Mubin, and the rest of the senior staff member, Professor Amna. Thank you so much, and Professor Tayyaba Wasim join us. Thank you so much joining here and gracing this occasion, and thank you so much.
Thank you, Madam. Professor Dr. Mehrunisa has very nicely emphasized that how all the departments of Mayo Hospital are assisting us 24/7. Now there is a small video that we shooted in Lady Acheson Hospital that is basically a reflection of obstetrical emergencies presenting in labor room and how our doctors are managing it and working on them to reduce the maternal morbidity and mortality is on the screen.
Hello, जी आयशा, डॉक्टर का इमरजेंसी में क्रिटिकल पेशेंट है, पेशेंट की 4 घंटे पहले लॉन्ग में डायलिसिस डिलीवरी कराई है और पेशेंट को बहुत ज़्यादा बीपी हो रही है, पेशेंट शॉक में है, मैं उसे लेके लेबर में आ रही फॉरन। ठीक है, आप पेशेंट को फॉलो ऊपर लेकर आए, इसका ब्लड ग्रुप क्रॉसमेट का सैंपल निकलवा दें तो एक अर्जेंट से भिजवा दें। ठीक है, ओके। स्टाफ एक पेशेंट आ रही है नीचे इमरजेंसी से, पीपीएच है और अपनी पीपीएच की रेडी करें। नवाज़ेश ठीक हो, आपके खोलो। स्टाफ जल्दी से पेशेंट को आईवी में अटैच करें दूसरी साइड पे और सैंपल निकाल के ब्लड के लैब में सप्लाई करें। डॉक्टर बेटा, ये पेशेंट का क्रॉसमेट का सैंपल है, ये आप फौरन नीचे ब्लड बैंक में लेकर जाएं, ब्लड अरेंज करवाएं पेशेंट का। डॉक्टर आयशा, आप फौरन एनेस्थीसिया टीम को ओटी में इन्फॉर्म करें, ओटी अवेलेबिलिटी चेक करें और पेशेंट के अटेंडेंट से हर दिस कंसेंट साइन करवाएं और काउंसिल करें उनको पेशेंट की क्रिटिकल कंडीशन के बारे में। सर हमारे पास लेबर में बहुत क्रिटिकल मरीज है जिसका बहुत खून बह चुका है, ये उसके ब्लड ग्रुप क्रॉसमेट का सैंपल है, मुझे फाइंड उस ब्लड ग्रुप का नॉन ऑर्डर बेसिस पे 6 बोल्डर और 4 एलएलबी अरेंज करें। मेरा पेशेंट आयशा पैराफोना वॉशरूम 0 followers daily expecting due to placental invader. Today is her 7th course of use. She was complaining of continuous favor for last 24 hours. Madam, on examination, her abdomen is soft, 6 times shows continuous serious ankle wounds, and mood is infected. ठीक है, इसकी टैबलेट स्टार्टिंग करो, केवल एंटीबायोटिक स्टार्ट करो, ब्लड कल्चर, यूरिक कल्चर, कॉल टू मेडिसिन केवल और इन्फेक्शियस डिजीज स्पेशलिस्ट को भी इन्वॉल्व करो।
Thank you for watching this video. Actually, this is emphasize the role of all the multidisciplinary approach in the obstetrical emergencies. Now I request the panelists of the scientific session to join us on the stage. Professor Dr. Shamsa Humayun, Professor Dr. Uzma Hussain, Professor Dr. Ibrar Ashraf. Sir, kindly join us on the stage so that we can begin the scientific session officially. With this, I hand over the mic to Dr. Alina Server for the further proceedings of the scientific session.
Thank you, Dr. Khadija. I am Dr. Alina Server, working as Senior Registrar in Lady Hutchison Hospital, Lahore. Now let us begin our scientific session, and if you have any questions from our speakers, you can ask in the end in the question answer session. In the start, we have a video message by Dr. Gohar Wajid. Dr. Gohar Wajid is a medical educationist and PhD scholar who works with WHO in Cairo, Egypt. And his message is about the Sustainable Development Goals and maternal health.
Gynecology and Edward Medical University for organizing an obstetrics conference with the theme Reducing Maternal Morbidity and Mortality the role of multidisciplinary teams. I believe this topic is very important and needs to be discussed repeatedly within the jurisdiction, especially from Pakistan perspective, because Pakistan unfortunately ranks high when it comes to maternal and infant mortality rates globally. Maternal and child health facilities are relatively better in urban locations in Pakistan, and they need to be substantially improved when it comes to rural and hard to reach areas. The boundaries of maternal and child mortality and morbidity issues, they extend far beyond the health domain and also include other socio-economic domains such as education, malnutrition, poverty, socio-economic status of the families, and even violence against women, especially in rural and remote areas of the country. So a multifaceted approach is needed, a multidisciplinary teams are needed that not only include health specialists but include key important stakeholders from other sectors as well. Now, this approach has been very well depicted in the recent Sustainable Development Goals developed by the United Nations. So, goal number three that pertains to health and well-being of the people is not only important, but other goals that relate to poverty reduction, improvements in education and socio-economic structures, and environmental issues, even they all play very important role in reducing maternal morbidity and mortality issues. So I believe that the team and the experts in this conference, they will be able to think broad and think holistic to improve the situation of maternal and child health mortality and morbidity in the country. Thank you so much and congratulations again.
I warmly welcome Professor Dr. Farah Yusuf and Dr. Sabahat, Medical Superintendent, Lady Wellington Hospital. Thank you for gracing the occasion.
Dr. Gohar has very well explained the role of multidisciplinary teams in achieving the Sustainable Development Goal related to the maternal health. Now, may I invite our first speaker of the session, Professor Dr. Asghar Naqi. He is the Dean of Surgery and Allied Health Sciences at King Edward Medical University, Lahore, and President of Society of Surgeons, Pakistan, Lahore chapter. He will be talking about the role of internal iliac artery ligation in obstetrical hemorrhage. Sir, please.
Thank you very much. First of all, I would like to congratulate the Department of Gynae and Obstetrics, Lady Aitchison Hospital, Professor Marunisa, and I am privileged to be your class fellow at King Edward Medical University. So congratulations, madam. Professor Tayyeba is also here, Professor Shamsa, and all of you. This presentation is actually focused for our surgeons in training, the obstetricians and gynecologists who are operating in emergency, and how these simple maneuvers can save the life of our patients. So, as already been discussed in the preamble of this conference by Professor Marilisa, it is a major cause of maternal mortality, and even in United States, 11% of maternal mortalities are because of postpartum hemorrhage. And in Pakistan, though this data is not very new, 21% of all maternal deaths are because of this postpartum hemorrhage. Now, the role of internal iliac artery ligation was first described by Kelly in 1893 when he was operating for a cervical carcinoma case and the bleeding from the uterine stump was not being controlled. Now, we all know that it can be really a life-saving procedure during that bleeding. What happens is when you bilaterally ligate the internal iliac arteries, it reduces the 49% of the pelvic blood flow. and the pulse pressure is reduced by 85%. And therefore there is venous pressure in arterial circuits, and thus it promotes hemostasis. Within seconds of ligation, blood enters the collaterals in retrograde fashion, and the practical effect is that pelvic ischemia does not occur, and yet you achieve hemostasis. And the most important thing is that despite bilaterally ligating the internal iliac arteries, the future reproductive potential is not affected totally. And even term pregnancies have been reported in the literature of patients who have undergone bilateral internal iliac artery ligations. Now, brief overview of the anatomy. We know that it comes from the common iliac artery and it divides into an anterior and a posterior branch at the sacroiliac joint. The anterior trunk then divides into the visceral branches, which supplies the pelvic organs and carry the blood to the external genitalia, and the posterior branch that supplies the pelvic wall and the gluteal muscles. The anteriorly lies the peritoneum. अभी हम उसको देखेंगे एक brief वीडियो में कि peritoneum कैसे anteriorly पड़ी होती है internal iliac artery की. Medial इसके ureter है, inframedial internal iliac vein है, lateral psoas major muscle है जिसके ऊपर external iliac artery पड़ी है, infralateral इसकी obturator nerve है. So if you look at this diagram carefully, you can see that this is the anterior branch. And whenever we talk about ligation of the internal iliac artery, we're talking about the anterior branch. We're not talking about the posterior branch. It divides into an anterior branch and a posterior branch, and the whole supply to the pelvic organs is coming through the anterior branch. So this is what we aim to identify and aim to ligate, and once it is ligated, you can see all the blood supply to the pelvic organs as well as the external genitalia would be controlled from here, especially when you do it bilaterally, because the pelvic organs and external genitalia have bilateral blood supply. Another very important thing is when you are working on somebody who has severe postpartum hemorrhage, there would be a lot of blood in the pelvic, and it may not be possible for you to identify the structures properly and to properly ligate the anterior branch of the internal iliac. So first of all, the first and foremost thing, and I have employed it multiple times, and this maneuver has saved many lives, is a proper pelvic packing. It causes a physical tamponade within the bony structures of the pelvis. And remember, the area that you need to pack is the true pelvis, which lies beneath the pelvic brim. सामने pubic symphysis है, फिर pectinate line है, पीछे sacral promontory है, ये pelvic brim की superior boundaries है. तो जब आपने pelvic packing करनी है तो आपने true pelvis को pack करनी है. And जब इसके टेम्पोनॉइड इफेक्ट की वजह से मेजर ब्लीडिंग रुक जाएगी, जो ब्लीडिंग pelvic वास्कुलेचर की है, जो वेनस ooze है, वो इससे बहुत अच्छा रुक जाएगा. इट वुड गिव यू टाइम to resuscitate your patients. It would give you time then to have clear anatomy of the area where you want to operate on that patient. Now this is how it should be done. You should only use larger 30 by 30 centimeter swabs which have those X-ray detectable lines in them, and they should be folded tightly. जिस तरह इनका रोल बनाते हैं ना, सैंडविच जैसे बनाते हैं, सैंडविच बना के करना है. और आप देख सकते हैं कि इसको पैक ऐसे किया है. ये प्यूबिक सिम्फिसिस ब्लैडर आगे है, उसने यूट्रस को चारों तरफ से पैक किया. बावल पीछे है, ब्लैडर आगे है, और ये जो रोल्स है ये ऑल अराउंड दी यूट्राइन स्ट्रक्चर्स राइट डाउन टू दी जहां तक पेल्विक फ्लोर जाता है. सो यू पैक. फर्स्ट थिंग यू वुड लाइक टू डू इज टू पैक करें, रिससिटेट करें. पेशेंट्स डिरेंड फिजियोलॉजी के साथ नहीं बच सकते. जिस पेशेंट को भी आपने देखा है जिसको DIC हो गया है, once the patient is in DIC because of bleeding, तो बहुत कम इम्कान है कि वो दोबारा कंपनसेट, जो डीकम्पनसेट हो गया शॉक, उस मरीज़ को वापस लाना बहुत मुश्किल है. तो सबसे पहले आपने जो काम करना है वो ये है कि आपने मज़ीद ब्लीडिंग को रोकना है, उसको रिससिटेट करना है, उसको एडिक्वेट ब्लड वॉल्यूम रिप्लेस करना है. ब्लड वॉल्यूम रिप्लेस करने का उस वक्त तक कोई फ़ायदा नहीं है जब तक नीचे से टैप खुला हुआ है. अगर बाल्टी के अंदर छेद है तो आपने उस छेद को जब तक पैक नहीं करेंगे, नया खून डालने का मरीज़ को फ़ायदा नहीं होगा. सो यू पैक फर्स्ट ऑफ ऑल, एंड वंस यू पैक, यू अचीव tamponade, you achieve or rather more comfortable area, then you think about ligating the internal iliac. And remember, you only ligate the anterior division. You do not ligate the common iliac, you do not ligate the posterior wall, because that would then take away the collateral blood supply to the pelvic organs. And जो हम कह रहे हैं कि हम reproductive जो potential है patient का वो कायम रहता है, वो फिर नहीं रह सकेगा. So there is a small video, and मैं चलाऊंगा, आप चलाएंगे? Can you please make it work? Thank you.
This video demonstrates the ligation of the anterior division of the internal iliac artery via the open technique. The uterus is kept under traction by the assistant. The round ligament is cut and its distal end is held using polyglide suture. The round ligament is then placed under traction. The peritoneum is then cut to expose the two leaves of the broad ligament. The incision is extended in a cephalic direction so as to make adequate room for dissection. At all times, the uterus must be placed under traction by the assistant. The areolar tissue in the retroperitoneal space is gently dissected off using blunt dissection. The assistant must be guided to retract the bowel. Once the areolar tissue in the retroperitoneal space is dissected, 3 tubular structures are identified.
एक मिनट के लिए रोकेंगे इस वीडियो को. कैन यू प्लीज स्टॉप द वीडियो फॉर अ मिनट? थैंक यू. अच्छा, ये 3 ट्यूबुलर स्ट्रक्चर्स है. द मीडियल वन हेयर, दिस इज द यूरेटर. ये जो श्वास के ऊपर पड़ा हुआ है, ये अपेंडिक्स वैसे आ गई है फील्ड में, इट्स नॉट इंटेंडेड टू बी हेयर. ठीक है, जो श्वास के ऊपर है एक्सटर्नल आइलिया का, ये एंटीरियर डिवीजन जा रही है ऑफ द इंटरनल आइलिया. ठीक. सो यूरेटर के बाद जो पहला ट्यूबुलर स्ट्रक्चर आपको नज़र आ रहा है फ्रॉम मीडियल टू लैटरल, दिस इज द एंटीरियर ब्रांच ऑफ द इंटरनल आइलिक आर्टरी. अब चला दें. थैंक यू.
The medialmost structure being the ureter, which is pointed by the right angle artery forceps. The ureter can be identified by peristaltic intent. The lateralmost structure, which runs over the psoas muscle, is the external iliac artery. In between these two structures lies the internal iliac artery.
So
the right angle artery forceps.
This is the anterior branch. This is the common iliac.
And laterally over the anterior division of the internal iliac artery. And the right angle is then passed from the lateral side to the medial side. Suture material is then passed underneath the anterior division of the internal iliac arteries. One can either use a polyglide suture or a self suture. One can either put a single ligature or can put 2 ligatures. Ligating the anterior division of the internal iliac artery, reducing the pulse pressure and the blood flow to the uterus.
Thank you. Can you please stop the video?
In cases where profound.
Okay, so this is how to do it on the patient. But remember, the first and foremost important thing is to properly resuscitate your patient. to make sure that no further bleeding is being done. And for that, pelvic packing still remains a very viable option which you should all be adept at, and which everybody and anybody who is on the operating team can do it properly themselves. You may need some training to do a properly anterior branch of iliac artery ligation, but for pelvic packing, you don't need much training. So I would implore all of you to first make sure that you are able to properly pack the true pelvis below the pelvic brim, achieve hemostasis, resuscitate, and then you proceed on to further management of this patient to make sure that the postpartum hemorrhage is controlled. Thank you very much.
Thank you, sir, for your wonderful talk. Now we have a small talk by Professor Dr. Azizunisa. She is the former Obs and Gynae professor at Ayub Medical Teaching Hospital, Ahmedabad, and the president of SOGP Pakistan. And her message is about the role of multidisciplinary team in reducing maternal mortality and morbidity.
Assalamu alaikum and good morning everyone. I am Professor Azizunisa, president at SOGP. Many congratulations to Dr. Aisha Malik and Dr. Meredith and the team for arranging such a useful workshop and conference. Thanks for inviting me. I am sorry I couldn't attend because of my personal commitments and sending a recorded message for this conference. And theme of the conference is how to reduce maternal mortality, which is quite common and very high in Pakistan. And recent demographic survey shows that two-thirds, nearly 80% of this MMR are due to two main conditions. One is PPH and second is eclampsia. And these two conditions are, there is no time. You need to treat the patient and give them first aid there and then before transfer to tertiary care hospital. So main objective of the SOGP is to do advocacy about these two conditions, to teach people working in the periphery who deal with the pregnant and patients and who attend them during delivery how to give first aid to these two conditions before referring them to the hospital. And at the same time, two-thirds of this, 80% of these deaths we get from the rural areas. So we need to go out of the big cities and work in the rural areas for advocacy, how to save these precious lives. At the same time, we need to talk about maternal nutrition and also birth spacing and contraception and sterilization. So have a very nice conference and thank you.
Now we have a message by Professor Dr. Tabinder Dugal. She is unable to join in person due to her schedule. She is the consultant endocrinologist and physician at Royal Cornwall Hospital, UK, and also the president of CAMTA, UK. And her message is about the role of physicians in the management of obstetrical patients.
अस्सलाम वालेकुम और बहुत बहुत शुक्रिया मुझे इस बहुत अहम टॉपिक पर बोलने के लिए कहने का और जो मेरा एक्सपीरियंस है पिछले तकरीबन 2 डेकेड से NHS में और इस करंट पोस्ट में तकरीबन 13 साल से जिसमें बहुत सारी MDTs रन करती हूँ. I work with my colleagues. At least 4 of my colleagues do MDTs with me, and it's a very good way to learn from each other. And not only do you learn for your own benefit, obviously, at the end of the day, you also benefit your patient. And if the patient is pregnant, then you obviously are benefiting 2 people at one time. So it is extremely important to have an MDT approach to management of patients who are across 2 disciplines or more than 1 discipline. And this is a newer concept for Pakistan, but I hope that it will catch on. I have got limited time to talk about it, and therefore I'm going to keep it extremely broad. I was asked to talk about reducing mortality in a very specific situation, but I am going to keep it extremely generic. So Melissa, I'm really sorry if this is something that you were expecting me to be very specific, but I am going to be very generic about the whole thing. So basically, I think the first step is to risk assess your patient, and pregnancy is always deemed high risk when the outcome is going to be different from someone who's having normal delivery. Therefore, it's extremely important to identify that patient who's going to need your expertise and other as a professional or more than another health professional. So more than one health professional might be needed to medication. Again, it moves on to labor as well. So high risk labor also needs to be identified, which is obviously the beginning of pregnancy to identify the person who's going to have high risk of labor. And as labor is a time of high physiological stress, you can have problems that develop at the time of birth. And this is totally avoidable in most situations, and this should be anticipated. Labor is a time of physiological stress, as mentioned before, and many conditions that may be dormant unfold at this time. And again, an open mind should be kept thinking outside the box and getting to the complications before anything adverse happens to the patient. And we know that in pregnancy and labor and delivery, it's not over till it's completely over. And therefore, until the baby is handed over to parents, any kind of problem may arise. And someone who was deemed to be low risk may have a difficult labor and may get problems during labor. And therefore, you have to be thinking on your feet and very quickly decide who you need to call for help at that time. Aside from a colleague, a person from another specialty center, maybe. It's a very useful document. I thought I'd show it to you and so that you can work through it and find it from the internet. This is from NICE, which is National Institute for Health and Clinical Excellence. And it's a 110-page document which details intra-partum care of women with existing medical conditions, obstetric complications, and their babies. It's a very detailed document. It actually tells you why a particular guideline was developed. So in depth topics are covered straight from things like heart disease to obesity of BMI 30 or BMI of above 30. A very, very comprehensive document, and I encourage you to have a look. Conditions that benefit from an NDT approach are obviously a very common condition, which is diabetes, which would be pre-existing or might develop in pregnancy. Hypertension, of course, developing during pregnancy or as a prior to pregnancy. Prior disorders of having postpartum or prior pregnancy existence. Heart conditions obviously get worse due to physiological strain on the heart because of increase in the volume, muscle volume, asthma, breathing disorders of any kind, a person with airway malformation and who may or may not have had a previous hemorrhage, risky of low degree, i.e. at least class 1, obese and above, and as well as kidney disease. Some of the disorders mentioned in the document that I previously mentioned, I have briefly mentioned, there are more common conditions specific. And I always believe that if you deal with the condition in time, i.e. you identify the population that will need you or multidisciplinary approach in time, you will always save the patient from any kind of harm. So stitch in time saves 9, which actually means on the right way to prevent it from getting worse and more difficulties in later. And so you should remember FRUS, which is an for formulation, review, update, and share. So formulate an approach with, in conjunction with the patient and use our shared decision-making guidance, again, available from the NICE website. The patient should be reviewed as they are. Patient should be updated if anything changes during pregnancy, and information should be shared with the woman's GP or other teams looking after providing care to this lady. The multidisciplinary team is usually comprised of many people, and you can pick and choose according to what your patient's needs are. It could be midwife obstetrician, a physician, or a physician with a very special interest in that particular condition, critical care specialist if needed, a surgeon, neonatologist, allied health professionals, midwives, obstetricians, obviously, and anesthetists as well.
Dr. Tabinda has clearly emphasized the crucial role which multidisciplinary teams can play in improving the maternal health. Now I would like to invite our next speaker, Dr. Faisal Sultan, who is the Chief Executive Officer of Shaukat Khan Memorial Cancer Hospital and Research Center. He is the USA trained infectious disease specialist, and he will discuss about the role of infectious disease specialist in maternal sepsis. I would like to request Dr. Aisha Malik to please join us on the stage.
Assalamu alaikum, everyone. I hope you're all enjoying this conference. What I'm going to do, look, I'll try to focus on the topic asked of me, but I'll provide a little bit of background and a little bit of surround to it. उसके गिर्द की कुछ बात थोड़ी सी मैं करना चाहूँगा. First of all, acknowledgement to my fellow Dr. Shahbaz, who helped put together these slides for me, and I'm grateful to him. We'll talk and focus on the issues of infections and critically ill patients, but we'll talk a little bit about what contributes to it or what goes around it. If you're going to reduce, देखें लगातार हम बात करते हैं कि पाकिस्तान में maternal mortality and infant mortality is high, and we all know this. But if we are going to solve for it, अगर इसको बेहतर करना है, ठीक करना है, तो we need to know what's going wrong. अच्छा, कुछ चीज़ें हैं जो हम sort कर चुके हैं, and fortunately the mortality numbers have actually come down. लेकिन एक interesting बात ये है कि after a while वो plateau कर गए हैं. They're really not coming down as fast as they should. I hope everybody understands and registers that. आपने वो जो low hanging fruits थे वो sort out कर दिए, जो periphery में हो सकते थे, जो primary obstetric care improve करके हो सकते थे, लेकिन after a point you have reached a deck, उससे नीचे ये numbers नहीं आ रहे. और क्यों नहीं आ रहे? क्योंकि जो further mortality है, it is coming from things like hemorrhage, eclampsia, sepsis, obstructed labor. What's common between all of these things? इन चीज़ों के दरमियान कदर मुश्तरक क्या है? वो ये है, ये वो तमाम चीज़ें हैं जो कि बिल्कुल पेरिफेरी में आउट इन द बियॉन्ड नहीं हो सकती. You require a little bit higher medical or surgical or obstetric care. Thus, this conference is crucially important. And आपके सारे topics जो चुने गए हैं, वो obviously they have been chosen with that in mind कि वो कौन से steps हैं, वो कौन से locks हैं जो हम unlock करें, तो फिर अगला further step down जो है into mortality आ सकता है. So this is crucially important. Please ध्यान में रखिए कि जो low hanging fruits थे, जो periphery में होने थे, वो किसी हद तक हो चले. अब जिम्मेदारी हम पर थोड़ी आ गई जो कि secondary और tertiary institutions में बैठे हैं, जिनके पास ये मरीज़ आते हैं और बीमार आते हैं. अच्छा, we'll talk a little bit about the magnitude of the problem. वो आपको बहुत ज़्यादा पता है. थोड़ी सी लिस्ट भी कर लेते हैं because बाकी conversations उसके गिर्द हैं. And a little bit about supportive care for critically ill patients, a little bit of peripartum sepsis, some specific management issues. अच्छा देखें, 2% of patients develop critical illness peripartum. अब ये unfortunately this is US data. I do know and I did notice Professor Abhay you presented some local data which is so important to know कि actually हमारे पास क्या हो रहा है. But ICU admission also ranges very broadly depending on the subset you choose. 1% से नीचे से लेके 13% तक. And US mortality is 17 deaths per 100,000 deliveries. Our numbers are higher, but I'm so happy that you are collecting them. और आपके चूँकि numbers high हैं, so therefore statistical validity जो है वो भी उतनी ही ज़्यादा अहम है. अच्छा, range of issues जो कि यहाँ discuss आज होंगे, कुछ हो चुके हैं, will have to do with cardiovascular disease, thromboembolism. There's a talk to follow on hematology issues, eclampsia I mentioned, acute respiratory failure, infections, A little bit about COVID-19, we'll not talk too much about it. Press and DKA and liver disease. So Tabinda spoke earlier on endocrine issues and the need for multi-specialty care. So I'll just narrow down on what I'm supposed to talk about now. That's sepsis. So really it's life-threatening organ dysfunction. छोड़े लंबी चौड़ी definitions को मुझे तो याद ही नहीं रहती. So life-threatening organ dysfunction from dysregulated host response because of infection. अच्छा, this is the third most common cause of maternal death. मैंने आपसे क्या जिक्र किया कि जब आप शुरू की आसान causes निकाल दें तो फिर रह गई hemorrhage, eclampsia, sepsis, perhaps obstructed labor. Half the problem in sepsis is कि इसका पता नहीं चलता, शुरू में पता नहीं चलता. And if we are able to recognize it early, we make a big dent. Shall I give you this very asan and crude example? If you give timely antimicrobials and timely management of appropriate antibiotics, the mortality is halved. आप दुनिया की कोई स्टडी उठा के देख लें, मेडिकल एनवायरनमेंट्स के अंदर, सर्जिकल एनवायरनमेंट्स के अंदर, ऑब्स्टेट्रिक एनवायरनमेंट्स के अंदर, if you give on time and correct antimicrobial, the mortality is half. तकरीबन 20-30% होती है. आप वक्त से ना दें, ठीक ना दें, 50-60% की गिल्ड होती है. This is all across the world. So एक तो मसला यह है कि we sometimes don't recognize it on time. Now, little bit step back कि sepsis की causes हमारे पास कहाँ से आ रही होती हैं. Obviously, the uterine infection itself from the primary organ जहाँ where all the action is going on. Septic abortions, crucially important in our world, and of course wound infections. लेकिन please keep in mind, और ये multi specialty की गुफ्तगू के अंदर very important, which is that they can come from outside of your immediate field. वो आपने गुजरता हुआ ureter देखा पास से जो आपको दिखाया जा रहा था with peristalsis. I couldn't tell whether it was peristaltic, but anyway, in the surgical field, perhaps it will be obvious. And of course, pneumonia, and many others. But these two are the commonest. So your neighborhood, just outside of your neighborhood, and far away in the lungs, in pe nazar rakhiye, because this is where sometimes the source is. Common organisms, really, I can list them out, I can name these, but to be perfectly honest, जैसे आप लोकल डेटा इकट्ठा कर रहे हैं अपने maternal mortality वगैरह के लिए, it is very important to collect this data कि आपका एंटीबायोग्राम है क्या, आपके पास organisms कौन से ग्रो कर रहे हैं और किस कॉन्टेक्स्ट में. So if I am an obstetric registrar, I need to know कि जो typical मरीज़ा मेरे पास आती है उसके अंदर जरासीम होते कौन से हैं, so that I can direct my guns at those. Classically, of course, the E. coli, streptococcus, staph, enteric gram negatives, occasionally fungal and viral infection. And there's this whole breakdown of all this. I will not bore you with this. आपके पास अपनी availability होनी चाहिए. You need to have the printout of what you see or what you are likely to see. अच्छा, शुरू में मैंने कहा कि ये ढूंढने मुश्किल होते हैं. It is hard to detect because जो unwell मरीज होता है वो unwell होता है, and sometimes it is easy to forget. You have an obstetric patient that is unwell because of obstetric reasons, and sometimes it is easy to forget कि ये outright septic भी हो रहा हो सकता है. The video that you showed, I noticed that the young doctor in it quickly rattles off कि कोई broad spectrum antibiotics भी दे दें. अच्छा, शुरू में, and it's very important, I'll say it again, but right now I'll say it initially as well, just to sort of make you remember it. In the beginning, it doesn't matter. Everything in the kitchen sink, जो मर्जी broad spectrum दें, ठीक है? De-escalate early, de-escalate sensibly later on, but शुरू में to give a broad spectrum antibiotic, nobody will argue with you if you have an unwell patient. अच्छा, क्या है जी, ये SIRS वाले numbers हैं, ये ज़रा sensitive हैं, वो Q SOFA है, which is a little bit more specific. अब अगर आप बहुत अपना sensitive parameter रखना चाहते हैं तो फिर आप वो SIRS वाले use कर सकते हैं. In other words, a respiratory rate of even more than 20 पे आप alarm हो जाएंगे. Whereas when you want to be a little bit more specific, just look up there, Q SOFA में 22 use होता है, और जो obstetrically modified SOFA है उसमें 25 है, so that you don't react to everything which may not be sepsis. So you can use any or all of these scores to get a sense of what is going on. Note कीजिए कि respiratory rate or systolic pressure and mentation seem to be a common theme amongst all these three commonly used parameters. इनमें से स्कोर 2 से बढ़ जाए तो आपको सोचना है कि क्या. अच्छा, what do? Do you get blood cultures or any other side? अच्छा, एक प्लीज़ आपसे दरख्वास्त है, ब्लड कल्चर्स लें तो अच्छी तरह से लें. हैव एटलीस्ट 10 ml ऑफ ब्लड इन द ब्लड कल्चर बॉटल. वो क्या है, कर्ज की पीते थे मैं और रंग लाएगी हमारी फाका मस्ती है, वो 2 कतरे खून के डाल के ना खुश होइए कि ये ग्रो करेगा, नहीं ग्रो करेगा. और फिर आप फ्रस्ट्रेट होंगे और कहेंगे हमारे यहाँ पॉजिटिव कल्चर्स नहीं आते. एक इसी शहर के इदारे में समबडी दैट आई नो वर्क्स माइक्रोबायोलॉजी में, दे कंप्लेंट कि जी हमें सैल्मोनेला पॉजिटिव नहीं आता. मेरा तो दिमाग ख़राब हो गया सैल्मोनेला पॉजिटिव से. आई गेट ऑल द फ्लैग सैल्मोनेलाज इन माई इंस्टीट्यूशन एंड आउटसाइड फ्रॉम एवरी सिंगल सेंटर दैट कम्स फ्रॉम शौकत खानम. There's a whole, every day we've got tons of these salmonellas and other gram negatives and positives. The key is please use the right bottle, put in enough and do it in time. बहुत देर से ना करें फिर आपकी yield गिर जाती. So blood cultures, any other site जहाँ आपको दिख जाए. Of course, what do you got to compare it with hypovolemic shock, hemorrhagic shock. PE ना भूलिए, very often easy to forget. MI, less common in women but not unheard of. It's there. We have a population that has enough coronary artery disease. Acute pancreatitis, DKA, renal insufficiency, and transfusion reactions. अच्छा, look, हम तो यहाँ मोटी बात करने हैं ना. I only have 10 minutes. I think I'm already going over it at this time. So I'll try to be very short. Stabilize the patient. एम्पिरिक एंटीमाइक्रोबियल, जैसे मैंने आपसे कहा शुरू में, वो एम्पिरिक किस पे बेस्ड होगी, विल टॉक अ लिटिल बिट अबाउट इट, बट इट्स बेस्ड ऑन व्हाट यू एक्सपेक्ट टू फाइंड, व्हाट यू थिंक इज गोइंग ऑन, एंड यू कैन बी रॉन्ग. सो देयरफॉर चूज ब्रॉडली इन द बिगिनिंग. तीसरा आइटम जिसको हम बहुत भूल जाते हैं, और मेरी आप सर्जन्स और सर्जिकल टाइप स्पेशलिटी से हमेशा थोड़ी बहुत हमारी इन्फेक्शियस डिजीज़ वालों की खींचातानी रहती है, सोर्स कंट्रोल. Now sometimes source control is not possible. Source control से क्या मुराद है, वो जो the dog in the well that has fallen, उसमें से डब्बे निकाल के पानी साफ नहीं होगा जब तक आप कुत्ता बाहर नहीं निकालेंगे. And therefore until and unless you actually take out what is probably causing infection, you will have failure of treatment. So source control बहुत अहम चीज़ है. Abscess है, ड्रेन करवा दें. Stitch abscess हुआ है, उसको ड्रेन करा दें. खुदा ना खास्ता if it's a larger problem then it's a tougher decision to do कि आपने what organ you can sacrifice at that time or should. And of course prevention of sequelae. ये नीचे एक टाइमलाइन से लिखी हुई है, इसमें मैं एक चीज़ बता दूं, पहला ये आइटम याद रखें सिर्फ. If you're going to just remember one thing, the 1 hour bundle. The first hour or 2 is crucial. Fluid resuscitation, antimicrobials, draw your cultures, get help. And then of course investigate source control and fetal consideration that you know 100 times better than I do. अच्छा, अब when I go and give a talk anywhere, people will say, अच्छा सर बता देना फिर कौन सी एंटीबायोटिक यूज़ करेंगे. And very often my answer is I don't know. Depends on what you have or what your organisms are and what the sensitivity profile of those organisms are. I really think it will be good if you go to your own micro lab or from wherever you get microbiology, उनसे कहें जी हमें लिस्ट तो दें कि कौन से जरासीम है और कौन से कितने MRSA है और कितना E. coli जो है वो फलानी चीज़ को सेंसिटिव है और उसको नहीं है. Only then can you really understand. But de-escalate quickly. अपने environment पे रहम कीजिए, अपने आप पे, अपने मरीज़ों पे. Please shut down after a few days. Antimicrobials, the growing evidence is that barring a few things, hardly anything is beneficial after a week or 10 days. Hardly anything. I can literally count those things on one hand जिसमें आपको लंबी एंटीबायोटिक्स चाहिए. TB फॉर एग्जांपल, ओके, वो भी उसमें भी सारी डायरेक्शन शॉर्टर की तरफ चली आती आ रही है. जब हम मेडिकल स्टूडेंट्स थे 9 और 12 महीने थी, अब 6 महीने है. विद बेटर रेजिमेंट्स में भी शायद इससे भी कम को आ जाए, बट फिलहाल 6 महीने. But that's an exception. Osteomyelitis, okay, fine, you're going to go longer. Most things, most bacterial infections will be sorted. वो battle won or lose हो चुकी होगी by day 8. Very few exceptions to that. Procalcitonin as a biomarker is useful. It's a slide to be not read. ठीक? This is a slide to be not read. I've just put it out there to remind you that this is a lookup item. This is not something that you need to remember. All of you have, and all of you should have, Can I have a raise of hand and see कोई up to date कौन यूज़ करता है या सैनफर्ड गाइड अगर नहीं करते प्लीज़ उसको डाउनलोड करें आप सब कोशिश करें उसको पे करने की बिकॉज हम उस चीज़ से अपने मरीज़ को फैज़ पहुँचाते हैं खुद कमाते हैं खाते हैं we need to be able to have the most up-to-date version of these resources. Don't remember this. No one remembers this. Don't need to. But what you need to know is that for each of these situations, hospital-acquired sepsis है, community है, skin and soft tissue है, urinary है, कहाँ की source है, endometritis है, you need to be able to look it up. But to look it up, you either need a small booklet in your hand or you need this little device that all of you have. कोई रह गया जिसके पास smartphone ना हो? So please use it. Please use it. COVID-19 के बारे में we'll talk very little, other than that its presentation is similar, but the risks are generally higher. So amongst pregnant women, your susceptibility to severe infection was the key issue. mRNA vaccines seem to be preferred, and the outcomes were not terribly different for miscarriage or congenital abnormalities, but preterm labor जो थी और stillbirth definitely increases थी. Preeclampsia का भी कुछ data ज़्यादा ही था. And we'll not talk too much on management because I think everybody's been through this a lot. So key takeaways, I'll stop after this. Again, many of these things will require ICU care. So please have friendly and beautiful relationships with your colleagues. All of us, none of us can really work without the help of each other. We sometimes need our surgical colleagues, sometimes the surgical colleagues need us, and so on. So please connect with them, talk to them. They're our best partners in providing great care. And I think pregnant patients की जो supportive care ICU में is very similar with a few exceptions. Multidisciplinary का पहले भी जिक्र हो चुका, मैं फिर आपसे दरख्वास्त करूँगा, talk to your microbiologist, talk to your physician, talk to your surgeon or your hematologist. And really, maternal sepsis in the peripartum period is also a potentially preventable and treatable cause, and timely interventions वक्त से कीजिए ताकि वो जो आपने हाफ करनी है mortality उसको आप करने में काबिल हो जाएं. I'll stop here. Really, there's nothing grand and fancy about this topic other than detection in time, response in time, get help, know your local data. Literally these four things. And if you do all this, inshallah, you'll be bringing the numbers down. And one of the first and most important steps to do it is to recognize your problem. And here we are in this room, in this beautiful room. I'm also a graduate of this college, but pehle maine kabhi ye nahi dekha. It's great to see it and great to enjoy this beautiful ambience. तो आपने आइडेंटिफाई किया प्रॉब्लम, आप सुन रहे हैं, उसके बारे में बात कर रहे हैं, and I hope that you'll all be able to contribute to this effort. Thank you.
Thank you, sir, for your very informative speech. Now I would like to invite our next speaker, Dr. Mizna Arif. She is Associate Professor of Hematology at King Edward Medical University, Lahore, and she will discuss about the role of hematologists in massive obstetrical hemorrhage and DIC.
Assalamualaikum and good morning to everyone. First of all, I would like to congratulate the organizers, Professor Dr. Mehrunisa and Vice Chancellor King Edward Medical University, Professor Dr. Mehmood Ayaz, for organizing such a wonderful international maternal mortality conference in King Edward. And I would also like to thank the organizers for inviting me to talk on massive obstetric hemorrhage and the role of hematologists. We call it fast and furious and frightening. The video, the documentary of Lady Aitchison Hospital that was shown, it was beautiful. I really liked it. And it was a depiction of fast and furious and frightening. What they were doing was trying to get to the problem fast and in order to avoid the furious bleeding and the frightening outcome that is, of course, DIC ultimately. So I'm sure you all know what obstetric hemorrhage is, but let's revise it. Since we follow British Society of Hematology guidelines, so according to that, the blood loss of more than or equal to 150 ml per minute or loss of 100% blood volume in 24 hours is massive obstetric hemorrhage. The next step in massive obstetric hemorrhage is to risk stratify, whether it's a low risk, medium risk, or high risk. Since for massive transfusion protocol initiation, we need to risk stratify the hemorrhage. As you can see that if there is a platelet count, decreasing platelet count less than 1,000 per cubic millimeter and hemoglobin less than 10 gram per deciliter, along with active bleeding and known coagulopathy. And also the placenta accreta that was also mentioned in the video as well. So that is high risk postpartum hemorrhage or obstetric hemorrhage. So next is the 4 hours of obstetrical hemorrhage, the readiness, recognition, response, and reporting. And of course, recognition is very important. Recognition and risk assessment is important. Unless you don't know what you are dealing with, you can't help the patient. So for that, you all know that tone tissue, trauma, and thrombin you look for. And as a hematologist, we look for the thrombin part, the congenital bleeding disorders, especially the acquired coagulopathies, anticoagulants, etc. I would like to mention here the congenital bleeding disorders की बात हो रही है, so I would like to mention that Von Willebrand disease. Von Willebrand disease is, mind you, it's very common in Pakistan, especially the type 1 and type 3 in some parts of Pakistan. It's common. And von Willebrand disease, it's uneventful during pregnancy because pregnancy itself is a procoagulative state, and the coagulation factors, they are increased by 500 to 1000% during pregnancy. So even if the patient is type 1 von Willebrand deficient, because in type 1 the factor deficiency is around 50 to 70. So during pregnancy, the levels are more than 100%. So nothing happens during pregnancy, and even nothing happens during delivery. But what happens is secondary massive PPH. The patient goes home and comes back with massive bleeding. And then, of course, the dreadful DIC and the consumptive coagulopathy. There are so many few diagnostic scoring systems, but as hematologists we follow two rules, rule of 30 and rule of 50. 30 is if hemoglobin drops by 30% after fluid resuscitation, and we should initiate massive transfusion protocol because till more than 50% blood volume loss without fluid replacement, that would be fatal. Now, what are the challenges? Time to start massive transfusion protocol. Of course, before assessment and risk stratification, you cannot initiate that. And then the type of components used and the selection of the amount that is to be given. So massive transfusion protocol initiation, we need to know what is massive transfusion. Again, it's total blood volume replacement within 24 hours or 50% total blood volume replaced within 3 hours. So the recommendation is, previously it was 2:1:1 approach. But now, recently, it's 1:1:1 approach. And I'm very happy, the video, the Lady Aitchison video in which the doctors were running around and taking care of the PPH patient, they were going for blood products, and I remember she said that she wanted 6 whole blood and 4 plasma. So the 1:1:1 approach is that first you have to use the components, the blood components, not the whole blood, ideally, and one packed RBC, one platelet, and one plasma. that would be 1:1:1 approach. It should be initiated within 5 minutes. And of course, O negative or positive, even it doesn't matter. RBCs, like RBCs and AB or A platelets and plasma. Um, I would also like to tell you that it's a misconception that grouping in crossfire takes a lot of time. I can assure you that grouping can be done within 5 minutes, and the immediate spin cross match you can get it within 15 minutes. So again, the next step is to send the baseline investigations, which the doctors in the video did promptly. And the goals, next comes the goals. What are the goals? What are we trying to achieve here? That we want the hemoglobin to remain at 10 mmol. And then platelet count more than 50, TT and ATTT less than 1.5 times in normal. And fibrinogen is very important here. It should be more than 100 milligram per day. What should be the blood products? Again, as I told you that it should be the blood components, ideally not the whole blood, and platelets, preferably mega units. Another thing that I would like to mention is cryoprecipitate. Cryoprecipitate is a wonderful blood component, and it contains fibrinogen, it contains 1 milligram factor, it contains factor 8, and it even contains factor 13. And the volume is pretty much less than FFP, fresh frozen plasma. So it should be an ideal choice for massive blood transfusion. Again, as I remember that as you have watched the video, that the doctor had a container in which there was 6 whole blood and 4 plasmas. So let's add 6:4:1, and 6 ideally should be packed RBCs, 4 plasmas, and 1 is platelet concentrate, preferably mega unit. And this 6:4:1 is what you call as the package, the massive transfusion protocol package. And usually there are 4 cycles with 3 packages each cycle. In Pakistani setup, in my clinical practice, I have not seen, due to constraints, lot of constraints like in our inventory of blood bank and resources, etc. We usually do have 2 packages in a cycle, and then usually 2 to 3 cycles are used or initiated during massive transfusion. Alright, so cryoprecipitate, again, I've already told you we should use it. It's really helpful. It's really helpful in massive transfusion protocol. Then again, it's a very another important aspect is DVT prophylaxis. Once if the patient recovers by the grace of God, then after it's all controlled, everything is under control, they are more prone to develop DVT. So DVT prophylaxis, of course, low molecular weight heparin and therapeutic dosage, 2 milligram per kg per day should be initiated. Of course, according to condition of the patient, not in everyone. Then there is disadvantages, of course, of massive transfusion protocol. There is trolley, there is transfusion-associated circulatory overload. But again, you have to do the risk versus benefit ratio, and massive transfusion protocols have really saved a lot of lives. As we are talking about the disadvantages of massive transfusion protocol, then coagulopathy is another big disadvantage. It's dilutional, it can be dilutional, it can be due to consumption, जो भी आप दे रहे हैं, that is being consumed, consumption of platelets and coagulation factors. So what can you say? We can say that after 8 to 10 units of packed red cells, the coagulation activity is at 25%. It's very, very low. 25% is very low. It cannot maintain hemostasis. So all roads lead to DIC. Everything is leading to DIC here. We have whatever you're doing, there is bleeding going on, and due to bleeding, you are giving. There is a massive fluid resuscitation. There is blood products you're giving to the patient, and this is causing dilution of coagulopathy. Then there is acidosis going on, there is hypothermia, patient is in shock. So everything and all is leading towards DIC, the dreadful DIC that we don't want to happen. But unfortunately, it does happen. So if it does, then how do you manage the DIC with PPH? So you need to break it down into components. Let's see, you have to check for hyperfibrinolysis. If there is hyperfibrinolysis, go for tranexamic acid. If there is fibrinogen deficiency, go for cryoprecipitate. And if there is thrombocytopenia, of course, platelets and coagulation factors, FFPs, are the mainstay for DIC. Then for factor 13, again cryoprecipitate. Recombinant factor 7, although it's off-label and bit controversial, but if all else fails and patient is hemodynamically unstable, then you are left with nothing but recombinant factor 7. And it can be given in a dose of 60 to 90 microgram per kg and can be repeated twice or thrice. I have never seen any patient surviving. If you have given recombinant factor 7 twice and it doesn't work, then I don't think that the third dose would work also. I've never seen in my clinical practice. It does have thrombotic complications, so of course again risk versus benefit, and if nothing is working, then recombinant factor 7 should be tried to save the precious life of the patient. This is the summary, and the take-home message, of course, is the 1:1:1 ratio. Please remember, and the component therapy and the DIC recognition is very important during risk assessment and the congenital bleeding disorders like von Willebrand disease. It's very important. And recombinant factor 7, and of course, time is money during massive transfusion protocol initiation, and you should be able to make quick decisions and very quick and very sane decisions, and do not hesitate to use whatever resources that you have. Thank you very much.
I would like to welcome our chief guest, Dr. Rashid Latif Khan, who has joined us.
I warmly welcome Professor Dr. Rashid Latif Khan, who is a teacher of all the teachers, and he needs no introduction. Sir has more than 5 decades of experience in the field of obstetrics and gynecology, and he is also a founder of IVF Society in Pakistan. Thank you, sir, for gracing this occasion. I welcome Medical Superintendent of the Lady Aitchison Hospital and Mayo Hospital, Dr. Munir Ahmed.
Thank you, Dr. Mizna, for your very informative talk. Now, may I request our next speaker, Professor Dr. Arshad Taki. He is a renowned anesthetist, intensivist, and member of critical care medicine at CPSP. He is also the former president of Pakistan Medical Commission, and he will give you insight about the role of intensivist in the management of critically ill obstetrical patients. Sir, please come on the dais.
Assalamu. Thank you for the opportunity to speak to all this august audience and express my views in this very important platform. I didn't bring any PowerPoint presentation. I'll just look at my clock and stick to my 10 minutes. I got a few messages. We were Dr. Call, and let me tell you that Dr. Call is the one person who actually introduced modern day anesthesia in the city of Punjab, Lahore in particular, and in Punjab in general. And it goes national as well. So we were having a discussion one day on maternal mortality, obstetric mortality, and we said, let's try to get some data. So he came up with a brilliant idea, invited all the heads of obstetrics units in the city of Lahore for a dinner in Punjab Club. And we said, we just want to gather data on maternal mortality. And that was back in 2006 or 7. So what we are going to do is we'll send a person to your department once a week, so by rotation. So 6, 7 actually obstetric units agreed to provide the data, and they said we'll just ask for two sets of information. One, how many deliveries during this week? How many deaths during this week? And second, if there's a death, you give us a brief note on why you think this patient died. It went on for 2 weeks, 1 year, then we stopped. Actually, 2 out of the 6 units managed to contribute that data. Others, of course, they were busy, so the person would go there, there would be no one there who had the time to provide that data. So, but 2 units, one from Lady Aitchison, one from Lahore General Hospital, actually provided us with that data. And interestingly, to my horror, there were 186 maternal deaths during that one period from those 2 obstetric units in the city of Lahore alone. Of course, they were very busy units. What we also realized was that the biggest cause for obstetric deaths in the Lady Aitchison was obstetric hemorrhage, and in Lahore General Hospital was maternal sepsis, postpartum sepsis. So that's something that was showing the trends. Our interpretation was that over here, these patients were kind of coming back and were going through home deliveries, and then were at some point referred, and by the time they reached there, they were actually accelerating and could not be survived, could not survive. And the other set from LGH was patients who were delivered at home and then developed sepsis and then were referred. So that shows us the trend, and that also shows us the what we need to do. Fast forward in 2016 and 15 or 14, we were with Professor Ashwati, and one of our consultants, Dr. Shamila, just said, look, hey, we are getting too many placenta accreditas now, and they are actually being referred from all over. So we were, let's look at the data, and we actually shared that data as well. Interestingly, the patients were being referred, and to us they were coming as electives because the diagnosis of placenta accreta was made. And then we looked at the panic that it caused because of we were not prepared, so we went on and involved all the surgical, the obstetric teams, and we said, look, let's just go and develop a protocol on how to deal with the placenta accreta. The maximum blood loss that we encountered in patients with placenta accreta was what was estimated to be about 30 liters. That patient was O negative. That patient had something like 20 transfusions on the table, packed her, sent her on, put her on a ventilator, took the packs out 48 hours later, 72 hours later, once again full stop the bleeding, sent back another 72 hours, but this time what he said was that that was the time when factor 7 that has just been mentioned was kind of being discussed. And there are those limitations to when you would be using factor 7. First, and there are certain limitations. No hypothermia, the patient, otherwise coagulation profile, which is PT and ABTT are normal, and there's no obvious surgical need. There we remove the pack, gave factor 7, and that patient survived. And that's the only time we have given factor 7 VR area for its use, a kind of like injudicious use in obstetric critical care. So moving forward, we developed a protocol, and that worked. And then coming back to the critical care part of it, we are encountering more and more patients with critically obstetric patients. Probably it's not that the number is increasing. That is increasing too because that reflects the population. It is actually increasing because people now we are getting more referrals. The patients are actually presenting instead of dying in those peripheral. So if we are to reduce, so my take home would be, so the what we find as killers in obstetric hemorrhage, we manage obstetric hemorrhage, uh, but and particularly in centers which have not really worked on their protocols, you are reacting to hemorrhage, you are transfusing massively. Most of the times, we are sold on the guidelines, so we actually go for factors. So we are asking for white cells, plasma, platelets in that 1 to 1 to 1 ratio according to the guidelines. What we don't realize is two things. A, while resuscitating aggressively, we are forgetting hypothermia. And hypothermia is actually the killer in these cases, as in case of trauma, as you would know. The second is we are forgetting the context. Our society doesn't work with this way. Our society works in a way that when you have a case of hemorrhage bleeding, everybody, the mohalla, the family, the hospital, there's that announcement made, they move in, they start donating, and you start transfusing. So we said, hang on, so let's just look at this data. So we looked at our data with something like 150 cases where we gave that fresh whole blood. So what we do is we would ask them to donate that blood a day earlier or in the morning of the scheduled when the plus this attack data was scheduled. Have 8 bloods there in the OR in a cooler, and of course they would be either used or discarded because once they were out, they were out. But also have a level 1 infuser because you cannot in any way transfuse warm blood through any other means except for the kind of massive transfusions that these patients require. Once they just bleed like liters within minutes. So we warm it, but we looked at our data. So what we did was at the end of our surgery, whether they were hemostasis was cured and they were sent back to the PACU or ICU, or we packed them or sent them back, we would just get a PT and INR done. And to see if there was any need for factors. So patients who had received those fresh whole bloods would have a normal PPIR. And we didn't manage in that series of 150, wherein our mean blood transfusion was 5.5 liters. We did not, 5 the blood loss was 5.5 liters, and the mean transfusions that we had given was something like 3 liters of 6 to 7 units of blood. There, we did not encounter a single case of coagulopathy. So there could be, and looking at the trauma literature, which is coming more recently from US war veterans and then from the civilian population more recently, there is a room for fresh whole blood. And if this is the way our society works, then why not use it? Why insist on having those patients, those whole blood? Yes, they're fine because they are logistically the best solution, but still, we need to find our own solutions. Coming back to critical care, it's a multidisciplinary thing. The issue is not in places like King Edward's Medical College, New Hospital, even ADHSN. The issue is to integrating the healthcare services and making them available to the marginalized populations. That's where we're going to decrease the maternal mortality. It means that it's an entire chain wherein you have a system of identifying those patients who are critically ill, having them referred to those centers which are capable of managing them. Every hospital or every peripheral hospital is not going to have developed that ability to deal with critically ill obstetric patients. We are having more and more patients with both peripartum cardiomyopathy. They are coming to us more frequently. We are having more and more cases of preeclampsia and its complications. So liver failure. We have had a few patients with strokes, coming with venous thrombosis. So we are having more and more, getting more and more of, seeing more and more of these patients who are critically ill, obstetric patients. The entire process of care would begin with identifying that set of patients early and having that team approach. It's more like a horizontal care. The anesthesiologist is just one of the cogs in that wheel. The critical care physician is just one of the cogs in the wheel. But it's more like developing the systems instead of looking at the individual. So that's my take home message, that if we want to really, then the specialties need to be talking to each other. Specialties need to be developing protocols and implementing them, and working across those silos of disciplines that we are used to working in. That's my little humble message for this conference. Great work, I must say. I must appreciate that King Edward's, like what is expected of them as the pioneers and as the pioneer of the most prestigious institution in the country, to actually come up, take a lead in these areas of interest to the public, and of importance to the public, and bringing all those specialties together. But the next step would be to come up with a set of guidelines which can then be taken to the. I was, and on the side note, and this is for the consumption of Professor John Raisa, Dr. Mehmood, and all the people in positions of influence today, that when we developed the critical care registry, I was a small part of that critical registry network, which is called PRICE in the country. I think the Edwards New Hospital has contributed to that. They should be if they are not. But based on that, we looked at the critical those quality indicators for low and middle income countries. And I was trying to talk to Healthcare Commission and requesting them that we need to develop a framework wherein all the critical care units from level 1 to level 3, wherever they are, would be based on those quality matrices that are developed collectively. So thank you very much. And thank you again for joining.
Assalamu alaikum. Warm welcome.
Thank you very much.
Our Vice Chancellor, Fatma Medical University, Professor Masood Gondal, and Professor Amir Zaman, ex-Vice Chancellor, Fatma Medical University. Thank you so much, sir, joining and gracing this occasion. Sir.
Thank you, Professor Dr. Ashir Taki, for your very informative talk. Now, this is the time for question answer, the time for the audience. If anyone is having any question, please name the speaker from which you want to ask the question. The mic will come to you.
I think that a lot of residents are sitting over here and the students are sitting over here. This was a very, very informative set, and it was designed in such a way that we should be able to address the issues of why is maternal mortality ratio in Pakistan so high. So I think that there will be a lot of questions, and maybe you are a bit inhibited कि शायद सवाल पूछेंगे तो कैसा अजीब सा लगेगा. कोई सवाल अजीब नहीं होता. Please come up and ask questions. And I see a team of very disciplined ICU nurses sitting over here. आप भी कोई सवाल पूछना चाहते हैं, आप सुबह से बैठे हुए, ज़ाहिर है कोई ना कोई सवाल आपके ज़हन में आया होगा.
आज आप अगर अनाउंस करें कि सिलिएस्ट क्वेश्चन के लिए आप एक प्राइज देंगे, सबसे जो बेवकूफाना सवाल होगा उसके लिए प्राइज देंगे, खुदा का वास्ता पूछो, कोई सवाल बेवकूफाना नहीं होता।
Gee, there is a question. Yes.
Yes, sir, when we talk of multidisciplinary approach, we must also take into account other factors which account towards the maternal mortality. These are adolescent health, early marriages, and also unplanned pregnancies, and not taking care of healthy timing and spacing of pregnancy, breastfeeding, and all the other factors which account for primordial, primary, and secondary prevention. These should also have been taken into account. Along with that, delays, the delay in decision, the delay in transportation, and third one, there should be delay level in provision of health care. We must have been taken into account these primary, primordial, secondary, and other two delays to have a multidisciplinary approach to reduce mortality.
Thank you, sir. Any other question from the audience? Yes, please.
My question is, what is the purpose of this conference that we are arranging, and these highly distinguished guests are there? इसका जो end pregnant है women है उसको इस conference का क्या फायदा है?
Thank you, dear student. So your name and your class?
नहीं आप बेशक अपना नाम ना बताएं, क्लास
Class.
सवाल आपका बिल्कुल
Your student actually, I think, joined late. In the beginning, when I talked and gave my, opening remarks, the agenda and the theme of the conference is on board. The theme is reducing maternal mortality, a multidisciplinary approach. And agenda is to take multidisciplinary on board. Team is on board to serve our critically sick patients because of maternal obstetric emergencies to reduce maternal mortality. So when a sick patient comes in emergency obstetric, yes, we are going to deliver, we are going to normal delivery or cesarean, but along with that, anesthesia department is there. Medical problems are going on. Like take the example of eclampsia, one of the leading causes. So many complications that we manage in collaboration with our multidisciplinary team. We involve the anesthetist, we involve the physician, we involve the, when hemorrhage is not being controlled, we involve the surgeon for internal artery ligation, and sometimes massive hemorrhage के बाद वो शॉक में जाती है, हमें ब्लड चाहिए होता है, ब्लड बैंक को हम इंगेज करते हैं, हेमाटोलॉजिस्ट से ओपिनियन लेते हैं, डीआईसी में है पेशेंट, तो बहुत सारे डिपार्टमेंट्स हैं जिनको हमें इंगेज करना पड़ता है। ठीक है, हमें एम्बुलेंस सर्विसेज चाहिए, एडमिनिस्ट्रेटिव फ्रेमवर्क चाहिए, ब्लड बैंक के ऊपर बहुत ज़्यादा स्ट्रेस होता है। तो इस सारी टीम को ऑनबोर्ड करना है कि दिस पेशेंट इज़ नॉट ओनली ऑब्स्टेट्रिक पेशेंट, responsibility of obstetrician, but the whole of the team is responsible and equally engaged to manage this patient. So in this regard, we have arranged this conference. So all the members from the different departments of Mayo Hospital are with us and they are managing. But through this conference, we are developing certain protocol. Say them thank you and different member of this team, when they are called, they have to leave their emergency to save our patient. So some protocol, some guideline, they should be there that they are going to manage obstetric patients as well, and they are part of this, active part of this team. So I hope I am able to explain the theme.
मैं थोड़ी सी बात कर लूँ इसमें। पहली बात है कि absolutely delighted to question, a brilliant question। मैं हम इससे बेहतर बात हो नहीं कर सकता, क्योंकि हमें ये जानना बहुत ज़रूरी है कि हम सब कौन हैं, हम यहाँ पे क्यों बैठे, हम क्या कर रहे हैं, मतलब ये तो सवाल बुनियादी सवाल है उसमें। तो थोड़ा सा मैं उसका जवाब आपको देना चाहूँगा। उसकी वजह ये है कि जो मैटरनल मॉर्टेलिटी रेशो है वो पाकिस्तान की हेल्थ केयर इस्टेब्लिशमेंट का बहुत बड़ा डायलेमा है। मुझे क्यों इसका एहसास हुआ, क्योंकि इस जो ये मीटिंग है, इस कॉन्फ्रेंस का इंस्टिगेटर मैं हूँ, मैंने कहा था कि ये हमने ज़रूर करनी है। उसकी वजह ये है कि जो किंग एडवर्ड मेडिकल यूनिवर्सिटी है, इसके साथ 7 एफिलिएटेड टीचिंग हॉस्पिटल्स हैं। Mayo Hospital, the largest of the teaching institutions of all over Asia, 3,000 bedded hospital. 2 dedicated hospitals designed to provide services to women who are on the family way, Lady Aitchison and Lady Wellington. Court Khaja Singh, Miyamunshi Hospital, Sam Minto Hospital, and Nawashi Ryaki Gate Hospital. So collectively, these 7 hospitals and King Edward, it provides healthcare facilities to whole of the inner city of Lahore, which is roughly 1/4 of the population of Lahore. जो maternal mortality ratio है पाकिस्तान का, that has been brought down from 227 per 100,000 live births to 167. But if you see the statistics reported, and I am quoting, a reference from international literature, जहाँ पे पाकिस्तान का mentioned है that the walled city of Lahore still has a mortality, this maternal mortality ratio more than 200. So when I read the statistics, it rang bells that why is it such so? जब हम किंग एडवर्ड मेडिकल यूनिवर्सिटी फैसिलिटी प्रोवाइड करिए तो हमारा एक पर्टिकुलर एरिया का मैटरनल मॉर्टेलिटी रेशियो तो बहुत कम होना चाहिए था, ये ज़्यादा क्यों हो गया है और मुसलसल चला आ रहा है। तो क्या कमी, देखिए कोई यूनिवर्सिटी अगर अपनी कम्युनिटी को हेल्थ सर्विसेज प्रोवाइड ठीक नहीं करी, उस यूनिवर्सिटी का राइट ऑफ एग्जिस्टेंस ऑलमोस्ट नेग्लिजिबल हो जाता है। हम बड़ी एकेडमिक्स पढ़ते हैं, बड़ा कुछ करते हैं, बट अगर हम अपनी सराउंडिंग कम्युनिटी को सर्व नहीं कर सकते, अगर हम ग्वाल मंडी को पीने का साफ पानी यूनिवर्सिटी फराहम नहीं कर सकती, तो उसका राइट ऑफ एग्जिस्टेंस कहाँ है? सो दैट इज व्हाई वी फोकस्ड ऑन कि जब मैटरनल मॉर्टेलिटी रेशो कितना है, उसके अंदर क्या क्या चीज़ें जो है ना उसके अंदर मौजूद है, बहुत सारी होती हैं, लेकिन हमने 5 बेसिक अवामिल को टारगेट किया है। The loss of life during labor, जहाँ पे hemorrhage is number 1, उसको कैसे कंट्रोल करना, इमीडिएट क्रिटिकल केयर में मरीजों को क्या रिक्वायर्ड होती है, उसके टॉप मोस्ट स्पेशलिस्ट को बुलाया गया, जब उनको इन्फेक्शन होती है उनको कैसे ट्रीट करना है उसको देखा गया, मल्टीडिसिप्लिनरी अप्रोच को कैसे देखा, सो वी इनवाइटेड टॉप मोस्ट स्पेशलिस्ट ऑफ देयर ओन फील्ड। यू सीन सिटिंग हेयर प्रोफेसर फैसल होता है, इनसे बड़ा इन्फेक्शन स्पेशलिस्ट कोई नहीं पाकिस्तान में, हमने इनसे रिक्वेस्ट की कि सुबह से हमारे पास है, हमने अरशद अली साहब से दरख्वास्त की, बट आप उसको स्पेशलिस्ट ऑफ पाकिस्तान, उनसे दरख्वास्त की वो यहाँ पर है। The Dean of the Faculty of Surgery, Azman Naki, the topmost surgeon, the President of Society of Surgeons, ने उनको इनवाइट किया। हमने लाहौर के तमाम बड़े टॉप गायनिकोलॉजिस्ट को यहाँ पर इनवाइट किया। हमने जो है ना जो इस यूनिवर्सिटी के वाइस चांसलर्स हैं उनको इनवाइट किया, प्रोफेसर आरिफ बोदर, प्रोफेसर आमिर जमान यहाँ पे बैठे, और इन सब के उस्ताद हैं, सबसे बड़े थे, जो पाकिस्तान की गायनिकोलॉजी की फील्ड में सबसे बड़ा नाम है। क्योंकि देखिए जब आपने मुशावरत करनी थी, हम तो मदद तलब करें कि हमारी मदद की जाए कि हम इस मैटरनल मॉर्टेलिटी रेशो को कम करना चाह रहे हैं, तो हमने जो हमारे से हो सका, जिससे हम कह सके, जिससे हम दरख्वास्त कर सके, सबने हमारी दरख्वास्त मानी। एंड टुडे वाज अ ब्रिलियंट डे वेयर वी कुड एक्चुअली आस्क प्रोफेसर राशिद लतीफ़, हम सब के उस्ताद के यहाँ पर आए और ग्रेस करें ऐसे टेबल और हमें रास्ता दिखा। बात यह है कि मैं बहुत खुशकिस्मत था, मेरे बड़े बड़े अजीम उस्ताद गुजरे, जिसमें एक मेरे अक्सर पे भी बैठे हैं प्रोफेसर राशिद, उन्होंने हमेशा में रास्ता दिखाया, रोशनी दिखाई। बट मैं अपने आगे तो समझता हूँ कि हम तो सिर्फ अंधेरा ही दिखा रहे थे, स्टूडेंट्स को रोशनी की तरफ नहीं लेके जा रहे। तो अपने उस्तादों से रहनुमाई तलब की, अपने दोस्तों से रहनुमाई तलब की, उसी के दरख्वास्त नजर है जिनसे कि आप हमें आके बताएं, पढ़ाएं, हमें रास्ता दिखाएं कि हम कैसे जो हमारे स्टिग्मा है कि हमारी जो मैटरनिटी मॉर्टेलिटी रेशो किंग एडवर्ड की विसिनिटी में बहुत ज़्यादा है, वॉल सिटी ऑफ लाहौर में, तो वो हम उसको कैसे काबू उस पर पा सकते हो। तो आपका सवाल बेटे बहुत ज़बरदस्त था, जवाब तो वैसा नहीं दे सका, लेकिन एक्सप्लेन करने की कोशिश की हम कौन हैं, हम क्यों यहाँ पे बैठे हैं, सब क्या करना चाहते हैं। शुक्रिया।
अस्सलाम वालेकुम सर, मेरा नाम मोहम्मद हाशिम खाबर है और मैं 4th ईयर MBBS से हूँ। सर आई वुड लाइक टू से कि हम इस कॉन्फ्रेंस में ये डिस्कस कर रहे हैं कि जैसे पिछली तकरीर में बात है कि लाहौर जनरल हॉस्पिटल में सेप्सिस में रीजन था मैटरनल डेथ का, न्यू हॉस्पिटल में, लेकिन सर पाकिस्तान के अगर कॉन्टेक्स्ट में बात करें तो जो गांव की औरतें हैं या हर जैसे इलाकों की ख़वातीन हैं, उनके मसाइल जो हैं वो ना ही यहाँ पे हम लोग इस तरह से डिस्कस कर रहे हैं, और ना ही वैसे आई नो कि वो उसका सोल्यूशन जो है वो हम सबके दायरा कार से बाहर है, लेकिन वहाँ पर जिस तरह के सोशल इकोनॉमिक इश्यूज होते हैं और सोशल स्टिग्मास होते हैं और उनके अपने मुआशरती लेवल पे भी जिस तरह के इश्यूज होते हैं, जिस तरह पेट्रियार्की है या उनके अपने पर्सनल इश्यूज हैं, तो उनको हम किस तरह से कैटर कर सकते हैं, मैं आपका जवाब जानना चाहूँगा। थैंक यू।
Thank you so much. I'm Professor Shamsa Moin. Thank you for inviting me here and giving me the opportunity to become more wiser. I would like to congratulate Professor Mahmood Ayaz, Professor Nisa and her team for organizing this very conference on pertinent issue. And inviting the galaxy of experts here. आपका जो सवाल है कि कैसे हम कर सकते हैं, these conferences basically and seminars are organized to sensitize, to create awareness. We all know the problems, जैसे कि हमारे president जो हैं आशु जी, उन्होंने कहा था we know how to save the mothers, but still they are dying. तो आपने जैसे बात की social economic issues हैं, there are cultural issues. If you just compare the statistics, पहले हमारा maternal mortality 400 से ऊपर था. So gradually we have improved. और अब हम अगर 220 या 240 या 180 पे हम आ गए और 167 पे भी आ गए, we know that in the rural areas maternal mortality ratio is still high. But आपके लिए मैं ये कहना चाहूँगी कि सोसाइटी ऑफ ऑब्स्टेट्रिक्स एंड गायनेकोलॉजी ऑफ पाकिस्तान एंड देयर आर सो मेनी अदर सोसाइटीज, दे आर वर्किंग इन द रूरल एरियाज, और वहाँ की मैटरनल मोर्टेलिटी भी कम होगी. और जब हम सारे एक्सपर्ट्स को यहाँ पे जमा करेंगे, एंड सिंस यू आर सिटिंग हियर एंड फॉर टुडेज talks, we came to know that teamwork is important. If you want to save a mother, you need to incorporate a team. जब माँ एक दफ़ा हॉस्पिटल में आ जाती है, तो then in the tertiary care hospital, if a mother dies, this means that we need to look back. हमें अपने SOPs रिवाइज करने चाहिए, हमें अपनी ट्रेनिंग इम्प्रूव करनी चाहिए, और जहाँ भी टीम काम करेगी, जिसके अंदर इन्फेक्शन कंट्रोल होगा, जिसके अंदर हेमाटोलॉजिस्ट होगा, क्रिटिकल केयर स्पेशलिस्ट होगा, ICU केयर होगी, we can save so many lives. रूरल एरियाज में भी काम हो रहा है, जब आगे प्रिंट मीडिया में जाएगा, सोशल मीडिया में जाएगा, so policy makers they are sensitized. And the objective of these seminars, these conferences is not only to improve the skills. हेल्थ केयर वालों की जैसे हमने आज बहुत कुछ सीखा, आपने बहुत कुछ सीखा, being medical associated with the medical community. इसी तरह से जो हमारी आम पब्लिक है, ये उसको सेंसिटाइज करती है और अवेयरनेस क्रिएट करती है. So we can save mothers. और here I would like to add one thing, that it's not the mother who dies, it's the whole family dies. Death of mother is death of the family. और प्रोफेसर राष्ट्रपति यहाँ पे हैं, ये हर कॉन्फ्रेंस में, हर सेमिनार में हमें यही कहते हैं, ट्रेन द TBS. आप जहाँ की बात कर रहे हैं, वहाँ ट्रेडिशनल बर्थ अटेंडेंट्स आर स्टिल देयर टू प्रोवाइड द केयर. So if we can train them, we can save maternal lives. And again, I would like to reiterate that teamwork, multidisciplinary team, हमारे बहुत सारे tertiary care hospitals में infection control specialist नहीं है, critical care available नहीं है, proper ICU नहीं है. So gradually we are improving. कभी भी ना उम्मीद नहीं होते, there is always hope. Since all of us we are sitting here and you are the torch bearers, next generation, inshallah, things will improve and we will one day bring our maternal mortality at the international level, which is less than 10 per 100,000. Thank you.
पहले तो शुक्रिया आपका कि आपने सवाल पूछा है. सवाल आपका जरूरी भी था, वैसा आपने बड़ा ही इसको कॉम्प्रिहेंसिव जवाब दिया, लेकिन मैं थोड़ा सा इसको एक और एंगल, एक और साइड से आपको इस चीज को एड्रेस करना चाहूँगा. देखो, आपने सही बात कही कि क्या सॉल्व करने की कोशिश कर रहे हैं, लेकिन हम ये सॉल्व करने की कोशिश कर रहे हैं तो 10 और चीज़ें भी पड़ी हैं। While the critique और commentary is correct, लेकिन मेरी दरख्वास्त है कि आप हमेशा ये भी सोचें कि जो चीज़ आपके सामने उसको पहले सॉल्व भी कर लें। हो सकता है वो जो थर वाला मसला है वो आपकी मेरी डायरेक्ट बराह रास्त लिमिट में ना हो, लेकिन जो चीज़ आपके सामने है। अपनी टॉक में मैंने थोड़ा सा इस चीज़ का जिक्र किया कि हमारी मॉर्टेलिटी एक जगह पे थी, उससे कुछ नीचे आई है। वो नीचे कैसे आई है, वो कुछ ऐसे इंटरवेंशन हुए जो कि प्राइमरी या होम एनवायरनमेंट में किए जा सकते थे। छोटी छोटी इंटरवेंशंस थी जो की गई और एक्चुअली उससे नंबर्स नीचे आए। अगर आपको इंटरेस्ट हो, मैं कोशिश करूंगा जुल्फिकार भुट्टा साहब की बड़ी इंपॉर्टेंट पब्लिकेशन है इसके ऊपर लिखा है और वो बड़ा वाज़ेह होता है कि एक स्टेप डाउन आया, लेकिन फिर वहां आके मामला कुछ थोड़ा सा रुक सा गया। जब एनालाइज किया उसके बाद लोग वादीन बन रही हैं, व्हाई आर दे डाइंग ऑफ दिस, तो ये देखा गया कि चंद एडिशनल कॉजेज हैं व्हिच सीम टू बी नॉट सॉर्टेड सो फार। उनमें हेमरेज थी, उनमें ऑब्स्ट्रक्टेड लेबर थी, उनमें एक्लैम्सिया था, उनमें सेप्सिस था। अब प्रॉब्लम ये नहीं कि वो चीज थी कि आप प्राइमरी डोमेन में नेसेसरली सिवाय वो प्राइमोर्डियल टाइप जो इंटरवेंशन है डॉक्टर साहब ने जिक्र किया उनके अलावा आप नहीं सॉल्व कर सकते। सो देयरफॉर वो तमाम चीजें आपकी कॉन्फ्रेंस में आज वन वे और द अदर एड्रेस होगी। एंड आई एंड ऑन अ स्लाइटली लाइटर नोट, मैंने हाउस जॉब की, मेरा हॉस्पिटल में यूनिट 5 होता था, मेडिकल यूनिट 5 का, वो शायद नहीं होता। तो हमारे मेरे एक सीनियर थे, मेडिकल ऑफिसर, नाम नहीं उनका था, ताहिर लाइक, बड़ा शॉकिंग टीचर और बहुत जबरदस्त बंदा, रियली रियली गुड कॉलीग, बाद में भी उनके साथ बहुत अच्छा मैंने काम किया। तो ये रूटीन था, लेडी विलिंगटन हॉस्पिटल से कॉल आती थी। अब वो कॉल आती थी वो एम्बुलेंस के थ्रू, फिर उसको कोई सरामा खरामा देखता था, फिर अपने काम खत्म करके अपनी जिम्मेदारियां भी तो थी ना, अपना यूनिट भी रन करना, फिर किसी का मूड आता था तो वो एम्बुलेंस में बैठ के जाते थे, फिर वापस आते थे। तो अल्लाह का करना ये हुआ कि हमारा जो दोस्त था, सीनियर था, उनकी मंगनी हो गई एक खातून से जो लेडी विलिंगटन में काम करती थी, तो तमाम कॉलें फटाफट अटेंड होने शुरू हो गई। बट वी कैन नॉट डिपेंड ऑन दैट ईच टाइम। तो कहने का मकसद ये है कि इस कॉन्फ्रेंस में जो होल सारा गुफ्तगू है वो मल्टी डिसिप्लिनरी कोऑर्डिनेटेड केयर की है। तो मैं समझता हूँ कि जो बीमार मरीज होता है ना, उसको बहुत से स्पेशलिस्ट की मशावरत की जरूरत होती है और उसको इफेक्टिवली एक जगह पे लाना, या उनके पर्सन के जरिए, या एल्गोरिथम्स के जरिए, या मेथडोलॉजीज के जरिए, या बंडल्स, केयर बंडल्स के जरिए, वो हम जब चीजें करेंगे तो इंशाल्लाह मॉर्टेलिटी कम होगी। तो वो प्रॉब्लम जो आपके मेरे सामने है, यानी हमारे डोमेन में जो हमारी वॉच के ऊपर जो हालत बन रही है, कम से कम हम उसको बेहतर सॉर्ट करने की काम। आई होप योर आंसर क्वेश्चन हैज बीन आंसर्ड। थैंक यू फॉर आस्किंग।
इससे एक चीज मैं भी ऐड करना चाहूँगा, डॉक्टर फैसल के कोविड स्टार्ट हुआ, डॉक्टर फैसल वाज running that entire operation against the COVID और उसको बहुत जोर मचा के वेंटिलेटर्स की शॉर्टेज है। At some point हम लोगों ने कुछ में कहा कि वेंटिलेटर्स को मिल जाएंगे, कहीं ना कहीं से मशीनें हैं भेजने वाले में मिल जाएंगे। Where do we have people who can actually run the ventilators? तो उस सिलसिले में एक कोर्स था जो रन करते थे बेसिक के नाम से, which was basic mental support in intensive care. Somehow इन लोगों ने जो people who were at the helm of affairs brought in health services academy, somehow arranged the funding, कहा गया कि जी अच्छा ये intensive course intensive, and remember वो टाइम था कि जब आपको कॉन्टैक्ट की प्रिकॉशंस और सब कुछ और तमाम एक्टिविटीज इसमें सबकी भी रुक गई थी। बट मूविंग फॉरवर्ड चाइनीज यूनिवर्सिटी हांगकांग ने किया था, उन्होंने कोलैबोरेट करके उन्होंने उसको हाइब्रिड कोर्स कर दिया, बहुत सारा कॉन्टैक्ट टाइम रिड्यूस किया। ओवर नेक्स्ट 4 months between the entire Lahore, Karachi and Islamabad, we managed to train like 5,000 doctors and nurses in managing critically ill patients. उनमें से 1500 लाहौर के शहर सेंटर किए। The idea is कि अगर हमें ह्यूमन रिसोर्स भी डेवलप कर दिया और उसके लिए बाकायदा ट्रेन बनाया गया कि जी अच्छा वो लोग करेंगे, तो फिर विजन ये थी कि आगे वो लोग हैं जो आइडेंटिफाई कर सकते हैं एंड देयर पीपल आउट देयर जो उनको वहाँ से डायरेक्ट कर सकते हैं, एज पॉइंटेड आउट एल्गोरिथम्स हैं और केयर बंडल्स बन जाते हैं। सो यू मे नॉट ID specialist in the city of Chand, but at least there's
a person who is telling you, ये वो तो क्या करना है, and patient and that kind of support is there. So ये processes सारे के सारे initiate किए हुए हैं, चलती रही हैं और इंशाल्लाह कहीं ना कहीं आके बेहतरी होगी और हो रही है.
हमारे पास मिडवाइफ्स बैठी हुई हैं. एक इंटरवेंशन जो इस वक्त इंटरनेशनल लेवल पे जब मिलेनियम डेवलपमेंट गोल द MMR वाज नॉट रिड्यूस टू द एक्सपेक्टेड, तो बहुत सारी रिसर्च हुई अफ्रीका एशिया में ये कम क्यों नहीं हो रहा, जो आपने थर की भी बात की है. तो इसके बाद उन्होंने कहा कि मिडवाइफ LHVs जो ये घरों तक जाती हैं, जिनकी रसाई है उन पेशेंट्स तक, इनको ट्रेन किया जाए. दिस इज़ वन ऑफ द मोस्ट इम्पॉर्टेंट इंटरवेंशन नाउ इंटरनेशनल लेवल पे कि ये बच्चियाँ ट्रेन और ये घरों तक इनकी अप्रोच है. तो दिस इज़ मोस्ट इम्पॉर्टेंट इन एशियन एंड अफ्रीकन कंट्री. इस लेवल पे बहुत सारा काम हो रहा है, स्लो है लेकिन हो रहा है.
Thank you very much, Professor Nirmal. प्रोफेसर महमूद अयाज ने आपसे जिक्र किया कि maternal mortality ratio जो है that has risen to 200 per thousand, and if you look into it, it's very high, and this is at the level of a disasters. And whenever there are disasters, what you are going to do is you are going to go for an evaluation, you are going to go for an identification, what are the various causes which have been discussed over here, and finally you are going to look for interventions. And whenever there are disasters, how we combat those disasters? The first thing is the prevention and mitigation. जो अभी MS साहब ने आपसे बात की थी कि what are the various factors which should be looked on before the patient is going to become pregnant. And then once the patient becomes pregnant and there is going to be that postpartum hemorrhage is going to be there, then this is going to be taken care by the response. And that response has to be adequate, and later on there is another area where a rehabilitation is required. Remember, our mother without a uterus after postpartum hemorrhage is going to have a huge psychological burden which should be taken into an account, and this is very much important. The third one is that we were talking of whenever there is going to be a problem, someone is going to take a leading role. And the leaders, they provide what? That is the vision. And this vision should come from the fraternity of the medical profession, that they are going to develop the guidelines. And these guidelines, if we are going to incorporate the larger group, that is going to develop the guidelines for the rural areas, for the primary and secondary care, for the tertiary care, and through that we are going to develop certain skill sets. हम जितनी मर्जी बातें करते रहें, leaders can't gain their vision without enabling individuals. We need to develop skill sets which are minimally required to save the lives of these mothers. And we should enable and inculcate these skill sets into our coming generation of doctors. It should not be that this is going to be provided by a doctor, it has to be comprehensive. There should be a team, a management protocols which should be ensured, and the skill set which is required at all levels, at the level of the, अगर आपने देखा हो कि सुबह जो हमें वीडियो दिखाई गई जिसके अंदर मेजॉरिटी यहाँ पे नहीं थे, उसके अंदर most of the work was being done by the nurses and the doctors. 70% was the doctor, 30% was the nurses, and there was no paramedic which was there. It's a very important component of our service delivery which is missing over there. So what we need is that we have to train all the factors which are going to be there, and they should be trained in such a fashion that the end result is that this maternal mortality ratio is going to go down. So my request to the Vice Chancellor, King Edward Medical University would be Today we have seen and we have identified that what are the various basic skills which are required to save these mothers. And we are going to develop a workshop for the postpartum hemorrhage care, which is going to be launched by the Department of the Gynae along with the skill department of the King Edward Medical University, and we will try that is going to be a way forward where all others universities, institutes and the societies, they can come together and we can develop those skills in our coming generation. Thank you very much.
I'm Dr. Aisha, the same postgraduate resident of Sir Robson Dining में. I wanted to add something कि यहाँ बच्चों ने जो बात पूछी as a student कि एक तो आम औरत को इसका क्या फायदा होगा, दूसरा मतलब what is the purpose of our sitting over there. As a student, if there are even 300 people, we are 300 doctors which are going to serve in 300 cities in the periphery. That includes maybe in Thar as well. अगर कोई सिंध या बलूचिस्तान या periphery से आया, अगर हमें बेसिक स्किल्स मिलेंगे, अगर हम यहाँ बैठे थोड़ा सा हम अपनी तवज्जो देके या कुछ बेसिक स्किल्स सीख लेंगे, हम अपनी periphery में जाके उसको implement कर सकते हैं, and then maternal mortality will be reduced. हमारे सामने पूरे पाकिस्तान से लेजेंडरी डॉक्टर्स आए हुए, डॉक्टर आशिफ, लाइक दीज आर आइकॉन्स. अगर हम इनसे कुछ सीख लें, अगर हम इनके दो लफ्ज़ सुन लें, डॉक्टर प्रोफेसर सुल्तान की कोई दो लफ्ज़ बात सुन लें, कोई हमें पता चल जाए कि इन्फेक्शन डिजीज़ को कैसे ट्रीट करना है, और एक प्रेग्नेंट औरत में अगर इन्फेक्शन डिजीज़ है या ऑब्स, या अगर आप में से सारों ने आगे पेरिफेरी करनी होती है, अगर हम अपनी ट्रेनिंग प्लान करें, मैं भी 2 साल पेरिफेरी करके आए, वहाँ के लेवल पे अगर हम थोड़ी सी अपने स्टाफ को ट्रेन करेंगे, we have midwives, we have nurses sitting with us, और वहाँ पे इंचार्ज होते हो, आप एक गांव के इंचार्ज होते हो, तो अगर हमें यहाँ बैठे हमारे बेसिक नॉलेज में कोई फर्क पड़ रहा है, then it is a step towards reducing maternal mortality in Pakistan.
Any other question?
Any other question from the audience?
Samir from first year business memory. क्वेश्चन है कि हम अपने सेटअप में maternal mortality को रिड्यूस करने के लिए क्या स्ट्रेटजीज अपना सकते हैं? मतलब जनरल तो हमें मालूम नहीं है, लेकिन स्पेसिफिक क्या हो सकती हैं, कोई हाईलाइट करते हैं?
Thank you so much. Another good question. अपना सेटअप DDHSN जहाँ हम काम कर रहे हैं, एक होलिस्टिक व्यू लेने की भी ज़रूरत है. फीमेल्स की एजुकेशन है, अवेयरनेस है. सबसे इम्पॉर्टेंट चीज़ तो ये है कि उनको पता होगा ये सर्विसेज अवेलेबल हैं. DDHSN में ये सर्विसेज अवेलेबल हैं, फैमिली प्लानिंग सर्विसेज हैं, ये सारी चीज़ें अवेलेबल हैं. और जब मैं एक कैंप किया था गोवा विलेज, यहाँ पे लाहौर के बिल्कुल अंदर है, साथ ही है, और वहाँ पे जब मेरे पास आ रही थी 18-20 साल की बच्चियाँ थी, 2-2, 3-3 बच्चे, और बिल्कुल 8-9 7 हीमोग्लोबिन, और उनको किसी की चीज़ का नहीं पता था. जब मैंने उन्हें बताया फैमिली प्लानिंग सर्विसेज हैं, लाहौर के ये हॉस्पिटल हैं, आप आएँ, DDHSN भी है, आप आएँ, तो उन्होंने कहा हमें नहीं पता. तो ये जो है ना बेसिक चीज़ें, इनको एड्रेस करने की बहुत ज़्यादा ज़रूरत है, और ये काफ़ी बड़ा मल्टी फैक्टोरियल इशू है पूरी सोसाइटी, और बहुत सारे चीज़ें जिनको ऑन बोर्ड लाना पड़ता है कि बच्चियों की अच्छी अप्रोप्रिएट टाइम पे शादी हो, दे आर वेल नरिश्ड हों, और उसके बाद उनको ये पता हो कि अब मेरी शादी है तो आगे प्रेग्नेंट होना है, मेरी उसकी डाइट है, और जो सर्विसेज एंटीनेटल हैं, इंट्रा, और फिर हॉस्पिटल आएँ, वहाँ पे आके बुकिंग कराएं, वहाँ उनकी हम देखभाल करें, ठीक है ना. तो ये वो सारी चीज़ें. बाकी अपने लेवल पे हम जो भी काउंसलिंग कर रहे हैं, जैसे हर लेडी आती है OPD में, वहाँ उनकी काउंसलिंग है कि ये कॉन्ट्रासेप्टिव मेथड्स अवेलेबल हैं. वहीं से ही हमने पार्टनर को भी एड्रेस करना है, जहाँ तक हो सकता है हम उनको भी बुलाते हैं, इंगेज करते हैं. जिनकी फैमिली कंप्लीट है लाइगेशन कराएं, जिनकी कोई ना कोई कॉन्ट्रासेप्टिव मेथड जो है वो आफ्टर डिलीवरी उनको हम दे के भेजें, ठीक है। और उसके बाद ब्रेस्ट फीडिंग हम इनकरेज करते हैं, वो कराएं। और ये हेल्थ केयर सर्विसेज हैं अपने लेवल पे हम प्रोवाइड करें। अनीमिया करेक्शन मैंने देखा वन ऑफ द बिगेस्ट, हर खातून जो आती है अनीमिया, हमारा इतना वर्कलोड बढ़ जाता है, तो उसके लिए क्या हॉलिस्टिक अप्रोच है, उनकी डाइट अच्छी करें, न्यूट्रिशन पे थोड़ा सा काउंसलिंग हम करें कि हर मदर जो है जब वो आती है हीमोग्लोबिन कम से कम 10 तो हो, आप ब्लड ट्रांसफ्यूजन दे के अपना वर्कलोड बढ़ा देते हैं। तो ये काउंसलिंग है और थोड़ा सा टाइम देना है अपने ओपीडी पे भी, इमरजेंसी में भी, वार्ड राउंड्स पे भी हम जो कर रहे हैं, ताकि हमारा मोर्टेलिटी रेट काफ़ी बेहतर आया। अभी जो हमने 22 का डाटा था, ऑल तो मेरे हिसाब से ये काफ़ी कम है, क्योंकि जो मदर्स मेयो में चली जाती हैं वो डाटा मेरा ख्याल है कि उनके पास है। नेक्स्ट ईयर से हमने उसको भी हमने ऑन बोर्ड लेना है, उन मदर्स को भी। तो ये चीज़ें हैं जो हम अपने लेवल पे कर सकते हैं। और बाकी ये जो कॉन्फ्रेंस है मल्टी डिसिप्लिनरी, और जहाँ जहाँ हमें ज़रूरत है क्विकली हम सर्जन्स हैं या फिजिशियंस हैं, एनेस्थेटिस्ट हैं, इन सब को ऑन बोर्ड करें एज अर्ली एज पॉसिबल। क्योंकि देखें ना, डिले घर से हुआ, वहाँ से ट्रांसपोर्ट नहीं है, आगे प्राइमरी कहीं गई है, सेकेंडरी गई है, हमारे तक पहुँची, यहाँ पे भी डिले ना हो। ये 4 डिले की वजह से फाइनली सेकेंड्स मैटर, तो वहाँ पे भी हम डिले ना करें, जितनी जल्दी हो उनको प्रॉपर ब्लड दें, उनकी हिस्टेक्टमी करनी है, लाइगेशन करनी है इंटरनल, वट एवर ये टाइमली हो, ताकि इसको हम सेव कर सकें। थैंक यू।
Thank you, madam. Now I would like to request Vice Chancellor Fatima Jinnah Medical University Lahore, Professor Dr. Khalid Masood Gondal Sahab, to please come on the dais and give your views about the theme of the conference.
Bismillahirrahmanirrahim. Thank you, Professor Mahmood Ayaz, for arranging such a wonderful seminar. और किंग एडवर्ड में आना तो नेचुरली ऐसे ही है कि मैं अपने ही घर में था और अपने ही घर में हूँ। और आज का आपका टॉपिक रिड्यूसिंग मैटरनल मोर्टेलिटी एंड मॉर्बिडिटी, आई थिंक दैट इज़ द नीड ऑफ द डे। और जो स्टेज पे इसको तशरीफ़ फरमा है, इसमें फैसल सुल्तान, आई थिंक बहुत बड़ी कंट्रीब्यूशन है हेल्थ सेक्टर में। फैसल 3 दिन पहले हम सिंगापुर में थे ना, माई सेल्फ एंड आमिर जमान, और टॉपिक था कोविड-19। इसमें सर्जिकल प्रैक्टिसेस और 8 ममालिक के लोग थे, और उसमें बाय द ग्रेस ऑफ अल्लाह अलमाइटी पाकिस्तान की प्रोग्रेस वाज वन ऑफ द बेस्ट इन कोविड-19, जिसमें दिस वाज द ओनली कंट्री जिसमें इमरजेंसी सर्जरी के अलावा वी डिड नॉट स्टॉप द कैंसर सर्जरी। इसी तरीके से आउटडोर जब बंद हुए तो टेली मेडिसिन का कंसेप्ट आ गया। वर्ल्ड एप्रिशिएटेड पाकिस्तान, हाउ पाकिस्तान बिहेव्ड इन कोविड-19, और मैं ये समझता हूँ इसका क्रेडिट डॉक्टर फैसल सुल्तान को जाता है। अरशद तकी साहब पीएमसी में बहुत बड़ा रोल, और फिर इंटेंसिव केयर में और कोविड में इनका अपना रोल। आमिर जमान साहब का ये कंसेप्ट था, ये रिसर्च जॉइंट रिसर्च हुई, दोनों यूनिवर्सिटी के वाइस चांसलर आमिर साहब मौजूद हैं, इब्रार अशरफ वेरी डायनामिक फिगर। और मुझे बड़ी खुशी हुई कि आज सारे ही गायनेकोलॉजिस्ट मौजूद हैं, फादर ऑफ गायनी तो मौजूद है, लेकिन हमेशा प्रोफेसर तैयब साहब मिस हो जाते हैं। आखिर में आ गया तैयब साहब, आपका बहुत शुक्रिया, आप मौजूद हैं। आयशा मलिक प्राइड हैं किंग एडवर्ड की और एफजे की आज की पेट्रन हैं। और मैं फातिमा जिन्ना मेडिकल यूनिवर्सिटी में गया तो वहाँ जाके जो मुझे एज ए बेस्ट टीम मेंबर बंदा मिला वो शमसा माइनो थी। शमसा आपका कोई मैच नहीं है, और इनकी कंटिन्यूटी में नौरीन अकमल हमारी इस वक्त प्रिंसिपल हैं, और उज़मा आप आई थिंक यू आर ए वेरी गुड ऑर्गेनाइज़र, लेकिन आपका 2 दिन पहले जो सेमिनार था उसमें आपने हमें मिस किया, आइंदा आपने मिस नहीं करना। और आपने मेहरुन्निसा को फॉलो करना है, जिस अंदाज में मेहरुन्निसा आई भी, इनवाइट भी किया, और खदीजा इनके साथ थी और हैं उसी अंदाज में। लेकिन आई मस्ट मेंशन 2 गुड एडमिनिस्ट्रेटर टू, सवाद भी बैठी हैं और डॉक्टर मुनीर चले गए हैं इस वक्त। और बाकी मैं सबका नाम लेना चाहता था, टाइम बहुत हो जाएगा, लेकिन नकी साहब और प्रोफेसर जोरा, आपका भी बहुत बड़ा ज़ारा इशरत जो है, बहुत बड़ा रोल रहा कोविड में। वेल डन किंग एडवर्ड मेडिकल यूनिवर्सिटी। अब चूँकि मुझे स्टेज पे बुला दिया गया है तो मैंने 5 मिनट तो लेने हैं बात करने में, और उस 5 मिनट से पहले आई थिंक वी मस्ट सल्यूट महमूद अयाज कि इस बड़े सेमिनार में फादर ऑफ गायनी आप बलूचिस्तान से चले जाएं, पंजाब के किसी हिस्से में, KPK में चले जाएं, किसी जगह पे चले जाएं, तो एक नाम जो गायनी में होगा वो प्रोफेसर राशिद लतीफ़ साहब का नाम होगा। अगर आपने वर्ड सुनना है, एक टीचर, एक मेंटोर, एक रोल मॉडल, एक बेस्ट ह्यूमन बीइंग, तो प्रोफेसर राशिद साहब का नाम आएगा। राशिद साहब का रोल एज द हेड ऑफ इंस्टीट्यूशन गायनी में, इनफर्टिलिटी में, पहला टेस्ट ट्यूब बेबी में, और सर आप पे तो पूरी किताब लिखी जा सकती है और 2 घंटे बात की जा सकती है। आपकी यहाँ मौजूदगी आई थिंक हम सब ऑनर्ड फील कर रहे हैं। और नाउ कमिंग बैक टू दी टॉपिक ऑफ गायनी, इस वक्त 4th ईयर के बच्चे मुझे नज़र आ रहे हैं। जब मैं यहाँ था तो आप लोग 3rd ईयर में थे, और मेरा गायनी का जो टॉपिक था वो अयाज साहब वाज द सीनियर रजिस्ट्रार एंड आई वाज द रजिस्ट्रार विद प्रोफेसर जफला चौधरी। का टॉपिक था गायनोकोलॉजिकल इमरजेंसी इन जनरल सर्जरी एंड देयर मैनेजमेंट। तो आज बात हो रही है मल्टी डिसिप्लिनरी अप्रोच, बात हो रही है सर्जन्स, एनेस्थिस्ट और इसके साथ गायनोकोलॉजिस्ट। तो मुझे उस वक्त याद है, ये बैठी है अपना नासरा राव हमारी रजिस्ट्रार नॉर्थ सर्जिकल की, और सर्जन्स तमाम बैठे हैं, कि जो म्यू की एमरजेंसी में पेशेंट आते हैं, अगर सस्पिशन ऑफ गायनी हो तो इन पेशेंट को रुलना नहीं चाहिए। आज का लेसन ये है कि सर्जन डील करेगा, गायनोकोलॉजिस्ट साथ होंगे और एक टीम की तरह पेशेंट की जान बचाने की कोशिश की जाएगी। और उस वक्त हमें क्या पढ़ाया गया कि जो गायनोकोलॉजिकल इमरजेंसी आ रही है उसमें से आप एक्टोपिक प्रेगनेंसी ले लें। एक्टोपिक प्रेगनेंसी अगर तो लीकिंग है तो यू हैव टू डिफरेंशिएट दैट फ्रॉम अपेंडिसाइटिस। अपेंडिसाइटिस में आएगा 4th ईयर वाले बच्चों, पेन एब्डामन, शिफ्ट टू द राइट इलिक फोसा, लोकल गार्डिंग भी होगी, टेंडरनेस भी होगी, लेकिन इसमें फीवर होगा, TLC रेज होगा। एक्टोपिक प्रेगनेंसी में राइट इलिक फोसा, यहाँ ना फीवर होगा ना TLC रेज होगा। आपने डिफ्रेंशिएट करना है, और एमेनोरिया किस्टी हो भी सकती है, नहीं भी हो सकती। और अगर एक्टोपिक प्रेगनेंसी होगी रप्चर्ड, तो हिस्ट्री होगी नाश्ता बना रही थी, फेंट हो गई और पेशेंट पीली आपके साथ पैलर कंडीशन में आई, तो आप ये नहीं कहेंगे कि भाई ये रप्चर्ड एक्टोपिक है, जाएं लेडी ब्लैंकडन लेडी एचसन में, नहीं, आप उसको उसी वक्त ऑपरेट करेंगे, सीनियर की हेल्प लेंगे, साल्पिंजेक्टमी करनी है, साल्पिंजोफ्रेक्टमी करनी है, साल्पिंजास्पी करनी है, बुला लें गायनोकोलॉजिस्ट को, और ये है मल्टी डिसिप्लिनरी अप्रोच, और ये है आज का लेसन। इसी तरीके से वो PID, अब इसकी मैं डेफिनेशन में तो नहीं जा रहा, अगर दोनों ट्यूब इन्फ्लेम्ड हैं, लोअर एब्डोमेनल पेन भी होगी, टेंडरनेस भी होगी, डिफरेंशिएट कर देंगे आप अपेंडिसाइटिस से। लेकिन अगर राइट ट्यूब इन्फ्लेम्ड है तो उसमें आपको डिफरेंशिएट करना मुश्किल हो जाता है, शिफ्टिंग की हिस्ट्री नहीं होगी, फीवर दोनों में होगा, और इसमें TLC रेज होगा, लेकिन डिस्चार्ज PID में होगा, विजाइनल डिस्चार्ज, अपेंडिक्स में डिस्चार्ज नहीं होगा। सो यू हैव टू डिफरेंशिएट इन दैट वे। इसी तरह मैं आप बाकी तमाम कंडीशंस की तरफ नहीं जा रहा, लाइक जिसमें ओवेरियन लार्ज ट्यूमर आ जाते हैं, इंटेस्टाइनल ऑब्स्ट्रक्शन ड्यू टू एडियंस आ जाती हैं, और मिडल शिमर सिंड्रोम जो मिड साइकिल पेन है, यू हैव टू डिफरेंशिएट फ्रॉम अपेंडिसाइटिस। लेकिन एक बात का ज़रूर तस्करा करूँगा जिसका स्टेज से तस्करा किया गया, दैट इज़ पोस्टमार्टम हेमरेज। जब पोस्टमार्टम हेमरेज का पेशेंट आपके पास आता है तो आप सर्जन को बुला लीजिएगा अपने पास, क्योंकि बाज़ औकात आपको सिजेरियन हिस्टेक्टमी करनी पड़ती है। सिजेरियन हिस्टेक्टमी के दौरान यूरिटर को आइडेंटिफाई करके बचाना पड़ता है, और इसके साथ बाज़ का इंटरनल आयरिक आर्टरी लाइगेट करना पड़ती है, और बाज़ का गलती से जब यूरिटर लाइगेट हो जाए तो उसकी डी लाइगेशन कैसे करनी है, स्टेंटिंग कैसे करनी है, कट गई और ड्रेन में यूरिन आना शुरू हो गया, यूरिटोनियोसिस्टोस्मी कैसे करनी है, सर्जन्स को इन्वॉल्व कर लीजिएगा, और ये है मल्टी डिसिप्लिनरी अप्रोच, और ये है आज का लेसन। सर अगर टाइम हो तो मैं घंटा और भी लेक्चर ले सकता हूँ, लेकिन इतने उस्तादों की मौजूदगी में मैं अपनी बात का इख्तिताम इस मुबारकबाद पे करता हूँ कि किंग एडवर्ड मेडिकल यूनिवर्सिटी इज़ द लीड यूनिवर्सिटी, और अयाज साहब को मैंने मुबारकबाद देनी है। दिस वाज द फर्स्ट यूनिवर्सिटी जहाँ गायनी में 4 न्यू सब स्पेशलिटी रिकग्नाइज हुई, जिसमें यूरो गायनी, गायनोकोलॉजिकल ऑन्कोलॉजी, फीटल मेडिसिन और रिप्रोडक्टिव हेल्थ, जिसके फादर यहाँ बैठे हैं, और माशाल्लाह 2 अपॉइंटमेंट यहाँ हुई, मुझे नज़र नहीं आ रही है उसका जैनब और इनके साथ जो सेकंड अपॉइंटमेंट थी। सो आपकी 4 सब स्पेशलिटी ये रिकग्नाइज हैं, आपको हमने फॉलो किया, और फिर MCH बना, चारों सब स्पेशलिटी FJ में आ चुकी हैं, और अब हम कहते हैं कि अयाज साहब वाइस चांसलर की गैलवेट के हैं, वाइस चांसलर FJ के हैं, और मैं और आमिर जमा दोनों यूनिवर्सिटीज़ के वाइस चांसलर हैं। मिल के हम कोशिश करेंगे दोनों यूनिवर्सिटी को लीड यूनिवर्सिटी ऑफ कंट्री बनाने की, और मैं ये समझता हूँ कि ये एक्टिविटीज़ बहुत इंपॉर्टेंट हैं। हेड्स ऑफ टू डिपार्टमेंट ऑफ गायनी, मेरुनिसा, एवरीबॉडी, थैंक यू केमकोलियन, थैंक यू नर्सिस स्टाफ, थैंक यू पैरामेडिक्स, थैंक यू वेरी मच, एंड थैंक यू मीडिया.
Thank you, sir. Now I would like to request Professor Dr. Amir Zaman, who is the former Vice Chancellor of Fatima Jinnah Medical University, Lahore, to please come and share his views about this theme of the conference.
Bismillahirrahmanirrahim and Assalamu alaikum. In the beginning, I'd like to be मेरे उस्ताद इधर बैठे हुए हैं, प्रोफेसर राशिद लतीफ़ साहब, एंड सर थैंक यू वेरी मच फॉर योर प्रेजेंस है। और आपकी प्रेजेंस से हम हमेशा कोई ना कोई लेसन लेते हैं, एंड आई एम श्योर कि जितना बड़ा आपका गायनी का नाम है, इंशाल्लाह हम आपकी प्रेजेंस से बहुत बेनिफिट करेंगे। आई एम वेरी थैंकफुल टू द वाइस चांसलर प्रोफेसर महमूद अयाज साहब for arranging this particular symposium or a seminar on a very important topic, that is the maternal mortality. Fatima Jinnah में भी we have a very robust department of gynae which is there, लेकिन सर आपका जो यहाँ का gynae का डिपार्टमेंट है प्लस लेडी HSL, और मैं कल in the presence of प्रोफेसर महरून निसा, और इसके अलावा you have 7 other affiliated hospitals के जिसमें gynae की सर्विसेज अवेलेबल हैं। और ये टॉपिक है, और मेरे ख्याल सबसे इम्पोर्टेंट बात ये है कि आपने आज जिन गैलेक्सी ऑफ पीपल को इकट्ठा किया, आपने फैसल को बुलाया, इन्फेक्शियस डिजीज़ के एक्सपर्ट, आपने तकी साहब को बुलाया, अस्कर नकी हैं यहाँ पे, इसी तरह मेडिसिन की टीम है, पैथोलॉजिस्ट हैं इधर, देन यू आस्क फॉर गौहर, और वो मेरे ख्याल इज़ ग्लोबल जो कि हेल्थ एक्सपर्ट हैं, जो उन्होंने मिलेनियम गोल्स के ऊपर शायद बात की है या करनी थी, एंड देन वी हैव अ मेडिकल एजुकेशनिस्ट। और मैं इब्रार की बात को सेकंड करूँगा कि वी शुड लीव दिस प्लेस जिसमें फिर हम कुछ ना कुछ जैसे एल्गोरिदम्स की बात करें, वी शुड लीव दिस प्लेस के जिसमें कि हम बात करें कि हमने कौन कौन सी कॉम्पिटेंसीज़ या वर्कशॉप्स डेवलप करनी है, और ये चीज़ें जो हैं बिकॉज दे आर वेरी इंपॉर्टेंट, एंड आई एम श्योर कि अगर ये सारी चीज़ें हों, वी आर द लीडिंग गायनेकोलॉजिस्ट है, डॉक्टर रुबीना इधर हैं, डॉक्टर तैयब हैं, डॉक्टर उज़मा, प्रोफेसर आयशा जो कि दोनों यूनिवर्सिटीज़ को रिप्रेजेंट करती हैं, दे आर ऑल हेयर। सो थैंक यू वेरी मच फॉर इनवाइटिंग मी हेयर, एंड आई एम वेरी श्योर कि ये सेशन जो है इट विल बी अ वेरी सक्सेसफुल वन, एंड वी विल कम अप विद सर्टन सॉल्यूशंस जो कि पाकिस्तान में मैटरनल मोर्टेलिटी को रिड्यूस करने में। आई एम सॉरी, मैंने प्रोफेसर शमसा चली गई हैं सर, ओके यार, हाँ अच्छी है, अच्छा इधर आइए तो मैंने मतलब देखा तो आप लाइन में नहीं थे। हाँ जी, कोई मसला नहीं है। सो थैंक यू वेरी मच वंस अगेन फॉर इनवाइटिंग मी।
Thank you, sir. Now I would like to invite Professor Dr. Rubina Suhail to please come on the dais and share her views about the theme of the conference. She has the practical experience of training the young doctors about the management of PPH in the form of PPH care bundle. Madam, please come.
Bismillahirrahmanirrahim. I think I should begin by saying salam to my worthy seniors. Professor Rashid Latief Khan is here, and senior people from the fraternity of gynecology and medicine are here. I think this is a very important topic, and it is very heartening to see that the topic is being discussed not only by the faculty of obstetrics and gynecology, but by other specialties as well. Maternal mortality is a dilemma which Pakistan is suffering from, and for which we haven't been able to do much. The Sustainable Development Goals of 2030 are right at our doorstep, and we are still struggling to make sure that our maternal mortality reaches the figure of 140 for all countries per 100,000 live births that we are striving to achieve. To me, I think that the effort that should be there is not enough, and the effort has to be increased. The way we did the campaign for dengue, the way we did the campaign for COVID, I think this is high time that we do a campaign for maternal mortality reduction. And if we want to reduce the maternal mortality, I think it is not only a team-based approach, but it is an approach of every person hands-on, which includes all the doctors, all the paramedicals, and it is again heartening to see the nursing faculty sitting over here, because you cannot form a team of only doctors. So the midwives, the nursing staff are very important members to be able to save the life of women. I'll just try to share a little bit of my experience with you all. In 1997, when Professor Rashid Latif Khan was actually a council member of FIGO, he brought in a project for us for reducing the maternal mortality. And our group worked from 1997 onwards for a period of 7 years for maternal mortality reduction in the district of Kasur, producing reasonably good results. But the problem with the projects is that the projects come and go, and the figures again start rising, because till the time that the government uptakes the various projects into concrete actions in the national program, maternal mortality is not going to reduce. The team-based approach is a wonderful approach, and I have a short story to share with you. So there was this man who had 7 sons, and they were continuously fighting with each other. And he was very worried that when he died, the sons are going to be torn away by the infighting that they were facing. So one day he brought them a packet of sticks, and he gave one stick to each of his sons, and he said कि इसको तोड़ने की कोशिश करो. तो बच्चों ने जब उसको तोड़ा अकेले अकेले तो वो सब टूट गए. So then he handed them the packet, and he said अब इसको तोड़ने की कोशिश करो. So they tried it, but they could not break that packet of sticks. So moral of the story is that if you work like a team, you will be able to save the life of the mothers as well if you apply it to maternal mortality. And that is what the PPH bundle approach says. So the PPH bundle approach basically is a set of interventions to save the life of the mother. And most of the interventions, most of us gynecologists already know. But the only difference in that set of interventions and what we are doing as a routine is that we put all the interventions together and act as a team to try to save the life of the mother. So I hope that with this maternal mortality conference on a very important subject, with this conference will come the realization, not only amongst the healthcare providers, but the government of Pakistan as well, that this is a very important issue which needs to be tackled on the basis of emergency, as does the population of the country. Thank you very much.
Thank you, madam. Now I would like to request Professor Dr. Muhammad Tayyab to please come on the dais and share his views.
Thank you very much, Dr. Faisal Sultan, Professor Rashid Latif Khan Sahab, Professor Mahmood Ayaz, Professor Gwanal Sahab, Professor Ibrahim, Professor Taki Sahab. It's a great privilege and honor to be here in the top institution of the country, and even a bigger privilege that a subject related to obstetrics and maternity, such a major impetus and impact is being provided by a gentleman who himself is a general surgeon, not an obstetrician, Professor Mahmood Ayaz. I'm very grateful for taking this to this height. And also, it's very difficult when a student has to come and speak in front of his teacher. Professor Rashid Latif Sahab, sir, he taught me how to hold a knife. He taught me how to take a history of an obs and gynae patient. He taught me how to clinically evaluate a patient. And that journey that began with the first history then took me through my journey of my obstetric career and training a lot of younger people. And I think this dilemma, I used to hear from my teachers that when they were younger, they used to hear that too many mothers die unnecessarily in Pakistan and the developing world. And now at my age, at this stage also, I hear the same thing, that too many mothers die in our country and in this part of the world unnecessarily, whose life can be saved. However, there is definitely an improvement over these 3 or 4 decades that I have practiced OBGYN. And that improvement sometimes is subtle and sometimes it's reflected in the data. And the subtle impact is, in 1992, I was training in Services Hospital, from where I went to the United Kingdom for 4 years. And when I came back to the same unit, again with Professor Rashid, and started working as an assistant professor, I asked one question that, when I was training here as a PG trainee or as a registrar, at that time there used to be a registrar, We used to have in our emergency every evening, every alternate evening, there used to be a van that came in front of Services Hospital with the patient either dead or half dead with a retained placenta and with the cord with with the clips hanging on the cord, and then we used to take her into the theater and take the placenta out. And I asked, where are those patients now? In 4 years, I've come back to the same institution after 4 years, and this emergency is not coming. And what happened? And this is between 1992 and 1996. And they said what has happened in these 4 years is that a lot of our younger girls who were doing DGO and MCPS, they have now occupied the periphery, the circumference of Lahore region. So what has happened is that these ladies who used to come from 100 kilometers, 150 kilometers, 200 with this emergency either dead or half dead, they are now handled at their doorstep with these younger junior colleagues of ours. And now this is something that is not written in textbooks or in data or whatever. And that is the major impact that's happened over all these years. And we also realize that maternal morbidity as well as mortality is not something which is handled by a trained obstetrician alone. Behind that, there is a political will. Behind that, there is resources. Behind that, there is finance. Behind that, there is literacy. Behind that, there is social awareness. And all these things are intertwined. So everybody has to work hand in hand. Just training 100 more obstetricians would not matter if you do not provide enough places for them to be taken care of and enough team members to take care of. Because all critical care in the world now is teams. It's not just one doctor. As long as the doctor is associated with nurses or paramedics or even an ambulance driver who are part of the team and know exactly what to do, this is not going to happen. And therefore, I think a lot is happening. And inshallah, we live with this optimism that we are going to get to the figure that Rabina quoted, that we probably, inshallah, are going to reach that level, that if we have come down from 500 to 350 and down to 250, let's hope we come down to 140. But once again, I'm very grateful to Professor Mahmood Ayaz for giving me this opportunity to be here and to learn from here in such a fully loaded program. And I think all my friends here, like I see Professor Gondal, Professor Amir Zaman, Professor Ayaz, they are general surgeons, but they're as passionate about maternal mortality, morbidity, and obstetrics and gynecology as they are about their own subject as well. I'm very grateful. Thank you very much.
Thank you, sir. Now I would like to request Professor Dr. Uzma Hussain to please come on the dais and share her views about the theme of the conference.
I am the Department of Gynecology and Professor Mahmood and Professor Nisa for organizing the conference on such important topic. Pakistan is one country which has a high mortality rate. It is unfortunate we are unable to bring down the mortality rate, and that is obvious. According to the 2000 millennium goals, we have to bring it down from the 275 mmR to 120. But at the 2022, we are still struggling at the 180 and 186. What is the reason? The main reason of the maternal mortality rate is a obstetrical hemorrhage and sepsis. How we are going to prevent it? We need a mass campaign to prevent. We need a mass campaign to create that awareness of antenatal care. We have to mobilize all the resources, available resources of the communication. And we have to improve the referral. We have to improve the referral system, because when we receive these patients, they are not moved, they are not with us anymore, or maybe at the verge of dying. So we have to increase the number of the skilled birth attendants. At the same time, the Dr. Mehrulisa said very well, it is the health workers that door to door to door. They provide this services in rural areas and remote areas, and that is very important. This is where the Bangladesh has improved this mortality rate that is below 120. I think by putting all these efforts, we have to attain the goal that is less than 120 or 120 by the year 2030. That is the target which are given to us, which is set to us by the WHO. Thank you.
Thank you, Professor Dr. Uzma, for your words of wisdom. Now I want to request worthy Vice Chancellor, King Edward Medical University, Professor Dr. Mahmood Ayaz, to kindly come on the dais and share his views regarding maternal mortality and morbidity in Pakistan.
बिस्मिल्लाहिर्रहमानिर्रहीम, अस्सलाम वालेकुम। वंस अगेन मैंने आपको सलाम किया, जवाब भी वैसे ही चाहिए। शुक्रिया बहुत बहुत। आपको मेरी आदत का तो पता चल गया होगा कि जब मैं सलाम करूं तो मुझे वापसी सलामती चाहिए होती है। बहुत शुक्रिया आपका। You have listened to all the speakers and all those people have spoken very well. और हमने इस कॉन्फ्रेंस का मकसद मैं आपको दोबारा नहीं गिनाऊंगा, लेकिन आपको इस कॉन्फ्रेंस का मकसद भी बहुत अच्छी तरीके से पता चल गया है कि वाई आर वी ऑल सिटिंग हियर टुडे एंड व्हाट वी आर फोकसिंग ऑन एंड व्हाट इज़ आवर पर्पस. And you have, listened to each and every person of his own specialty, the topmost specialist in his own specialty. And that is why we were asking for this multidisciplinary approach, because it's very important to remember and always remember that the maternal mortality and morbidity is one of the highest in Pakistan. ये जिस तरह की हाईएस्ट नंबर हम देख रहे हैं, शायद आपको वेस्ट में उस तरह के नंबर्स नहीं मिलते, बट 99% ऑफ द मैटरनल मॉर्टेलिटी अकर्स नॉट इन दी डेवलप्ड कंट्रीज बट इट इज़ इन दी अंडर डेवलप्ड कंट्रीज, जिसमें से हमारा मुल्क इसमें शामिल है. And you can very easily understand that when there is a mortality of a mother, what happens to the children, what happens to the family, what happens to the community, and as a whole जो healthcare system है उसको that is seriously affected. तो मेरी दो ही गुजारिशात हैं, इतने सारे जो मशहूर लोग सामने बैठे हुए हैं, कि दो एरियाज़ पे हमें टारगेट करना बहुत ज़रूरी है, एंड दैट इज़ व्हाट वी आर गोइंग टू फोकस ऑन. द फर्स्ट इज़ दैट वी हैव टू मेक श्योर दैट देयर इज़ अ ट्रेंड लाइव birth attendant which is there at the time of birth, a trained birth attendant, चाहे वो एक trained nurse हो, चाहे वो एक trained doctor हो, who can ensure that the delivery is clean and safe, and the attendant, the birth attendant can recognize that what is prolonged labor, what is infection, what is hemorrhage, and when it is the time to actually refer this patient. और दूसरा इसका component है that we should be able to provide a comprehensive essential obstetrical care. I'm not against provision of this basic essential obstetrical care, लेकिन comprehensive obstetrical essential care available होनी चाहिए for all those mothers who actually require that. और ये बहुत ही important है, because जैसा भी फैसल ने आपसे जिक्र किया, everybody has laid his or her emphasis on the typical topic which was given to them. लेकिन the first hour after delivery and the first month after the delivery, they're the most important areas जहाँ पे हमने टारगेट करना है कि हमने इन्फेक्शंस को कैसे कंट्रोल करना है, हमने क्रिटिकल केयर कैसे प्रोवाइड करनी है, हमने ब्लड ट्रांसफ्यूजन के अंदर जो मिसहैप्स होते हैं उनको कैसे देखना है, हमने अल्टीमेटली जो है ना मॉर्बिडिटी को कैसे रिड्यूस करना है, पोस्टमार्टम मॉर्बिडिटी को कैसे रिड्यूस करना है, तो उसके ऊपर फोकस करना है. But before I actually go on, because we have got a small ceremony ahead और हमें प्रोफेसर राशिद को भी मौका देना है, लेकिन I want to share a very personal story. बहुत कम मैं शेयर करता हूँ इसको, but I would share this personal story because this is very important. This personal story is very important for us. So प्रोफेसर राशिद लतीफ़ साहब, सर मैं आपको एक पर्सनल स्टोरी शेयर करने लगा हूँ. वो इस तरह है कि I was born in Peshawar at Lady Reading, 17th October 1960, 3 a.m. in the morning. And I had an issue of birth survival. My mother had an issue. So I was transported from Peshawar by my father to Lady Wellington Hospital. And I reached here at 3 p.m. in the morning, 12 घंटे के सफ़र के बाद, with my father in a small van. तो मेरे दो बर्थ सर्टिफिकेट्स हैं, एक लेडी रीडिंग का और एक लेडी वेलिंगटन का. तो समटाइम्स आई एम क्वेश्चन कि तेरे दो बर्थ सर्टिफिकेट्स क्या, लेकिन रिकग्नाइज्ड इस्टेब्लिश्ड दो बर्थ सर्टिफिकेट्स हैं. सो दैट इज़ वाई आई हैव गॉट टू डोमिसाइल्स, एक वहाँ का है पेशावर का और एक यहाँ का. आई स्टिल स्पीक दैट टंग दैट लैंग्वेज एंड आई स्टिल स्पीक पंजाबी एज वेल. तो ये तो यहाँ पे हिस्ट्री थी, लेकिन हिस्ट्री यहाँ पर ख़त्म नहीं हुई. I remained admitted at Lady Wellington Hospital for 2.5 months. My mother was brought later about 12 days back to Lady Wellington Hospital. और मेरा once again कोई survival का issue था. I don't know what happened to me, but I actually came out of Lady Wellington after 2.5 months. My mother would go daily from Lady Wellington to Data Darbar to pray for me, and somehow the other I survived. But that survival was with a price. And once again, I don't know what happened to my mother, but my mother had some psychological issues. So from Lady Wellington Hospital, after 1 month, she was shifted to Punjab Institute of Mental Health. मैं इस चीज़ को छुपाता नहीं हूँ, but she was there for 1.5 years. I was sent back to Nashara to be raised by my grandmother. So I am absolutely indebted to those people who actually managed to actually make me survive. I don't know who was the gynecologist, who was the pediatrician, लेकिन बाद में एक pediatrician जिन्होंने बाद में मुझे support किया सारी उम्र, डॉक्टर अनवर, अगर आप उनको याद हो तो वो मेरे हमेशा से knowledge रहे, because I had an issue to speak. मैं बोल नहीं था सकता, समझ नहीं थी आती कि मैं बोल क्यों नहीं सकता, लेकिन it was a mental trauma or living away from my mother, whatever happened, but I could not speak. तो लोगों का ख्याल था ये गूंगा है, ये कभी बोलेगा ही नहीं. बाहर बोलना भी शुरू किया और बोलता ही गया और बोलता चला गया. लेकिन जो मैं आपको एम्फोसाइज करना चाह रहा हूँ that the kind of care which was provided to me and my mother in 1960, and then the subsequent care which was provided to my mother at Punjab Institute of Mental Health, she managed to actually come out of that, and she went back to Kinnaird College जहाँ पे study करती थी. She did her masters from Kinnaird College, and now she's a very very proud mother, 86-year-old, and silently हमने कभी उसको जिक्र नहीं किया, but one of the greatest philanthropists I've ever known. And there she has a very proud son standing in front of you as the vice chancellor of one of the oldest universities. तो ये जो सवाल था मल्टी डिसिप्लिनरी का, जो किसने पूछा था कि आप ये क्या कर रहे हैं, तो मेरे बैकग्राउंड ऑफ माय माइंड वाज कि ये बनाना ही बनाना है, क्योंकि जब ये बनेगा तो शायद वो प्राउड मदर 62 साल के बाद सर्वाइव करती हो, अपने बेटे पे फ़ख्र करती हो, और वो बेटा शायद वही बेटा जो सर्वाइव नहीं था कर पाता किसी ज़माने में, आप ही इन मदर्स को बचाएंगे, उन्हीं बच्चों को बचाएंगे शायद कभी वाइस चांसलर्स बन सकते थे. सो दिस वाज माय पर्सनल स्टोरी. सो दैट वाज द रीज़न बिहाइंड ऑल दिस. वी हैड टू डू दिस एंड वी विल कंटिन्यू डूइंग दिस बिकॉज I want to have all those proud mothers boasting about their sons, and I want to have their proud sons standing here someday on these forums, having big positions and telling this story again and again that yes, we are indebted to our gynecologists, yes, we are indebted to our psychiatrists, yes, we are indebted to pediatricians, and yes, we are indebted to everybody who takes care of the mothers and their children to make them survive. And that is what I wanted to say. Thank you very much.
Thank you, sir. To pay tribute to Professor Dr. Aisha Malik, who has served this institute for more than 25 years. She acted as Dean of Obstetrics and Gynecology from 2019 till 2023 and recently been transferred to Fatma Jinnah Medical College, University. Madam has worked at various forums to improve the maternal health, and there is a small slideshow in her honor that is on the screen.
Gynae Department of Edinburgh Medical University is the largest gynecological hospital in Pakistan, comprising of 5 units in 2 hospitals, which are Lady William Hospital and Lady Aitchison Hospital, led by our head of department, Professor Dr. Aisha Malik, since 2019. Professor Dr. Aisha Malik is a Campbellian and served in Edinburgh Medical University for more than 25 years. He joined Lady William Hospital in 1997 as senior registrar and became professor of obstetrics and gynae in 2009. Lady William Hospital and Lady Aitchison hospitals are the busiest hospitals with annual delivery rate exceeding 20,000 per year, and this workload has doubled in the last 5 years. We as department are always committed to provide best standards of patient care with limited resources to high-risk obstetric patients. And through personal efforts, the department have upgraded the labor wards. To decrease the maternal mortality, we have conducted series of workshops to train our daily health visitors, midwives, and nurses in emergency obstetric care. Our extraordinary achievements during Professor Aisha Malik's tenure include cervical cancer screening program for healthcare providers from 36 districts of Punjab. dedication in her chosen field of gynecology is shown by her continuous efforts to introduce gynecological subspecialties, including gynecological oncology, urogyne, and reproductive medicine. Lady Lincoln Hospital is the first government sector hospital currently offering IUI to its clients, and low-cost IVF is also in pipeline. Teaching being profession, Professor Aisha is supervisor and examiner for CPSP since 2003. She has more than 250 postgraduate trainees to her credit, serving all over Pakistan and abroad. He also has published various researches in local and international journals. We as department have worked together and relaxed together as a family. Our vision is to build a 200-bedded emergency block in Lady Lincoln Hospital, and its PC1 has already been approved. Madam, we all thank you for playing your role in the journey of King Edward Medical University.
This video has shown the remarkable services of Professor Dr. Aisha Malik for this institute. I warmly welcome Professor Farhana from Anatomy Department. Now I request Professor Dr. Aisha Malik to kindly come on the dais and give her opinion about the maternal mortality and morbidity in Pakistan.
Respected Professor Rashid Latif Khan, my teacher, my mentor, and my examiner in FCPS, जिन्होंने मुझे ये डिग्री दी, Vice Chancellor King Edward Medical University, Professor Mahmood Ayaz, Vice Chancellor Fatma Jinnah Medical University, Professor Khalid Masood Gondal, Professor Faisal Sultan, Professor Amir Zaman, all respect Professor Tayyab, also my teacher, Professor Rubina Zuhail, and my colleagues from the basics and surgical departments. I am humbled and honored by this tribute. I have been associated with King Edward Medical University after my student life for 25 years or more. And I have worked as senior registrar and then moved on to being professor, then head of the department, and then a dean of surgical and allied. But in titles, की वो importance नहीं थी. The importance was the love and the respect that I enjoyed and had the privilege of while working in this great institution. And I think कि एक lifetime में इससे ज़्यादा honor और love का आप imagine नहीं कर सकते. So I'm very grateful to the whole institution for honoring me. Thank you. I would especially like to thank Professor Mahmood Ayaz, our Vice Chancellor, who's a source of inspiration and guidance for all of us. I would also like to thank my colleagues, Professor Uzma Hussain, Professor Kiran Khurshid, Professor Amna, and Professor Mehrul Nisab for organizing this conference today. We worked together as a team, and I think it was the best example and tenure in which we organized academic workshops, we trained people, and we made our best efforts to reduce maternal mortality, जिसकी कुछ हमने जो कोशिशें की वो आपने slides में देखी. To the final year, I would like to give one message, क्योंकि हमारे students भी हैं और हमारी nursing staff भी है. So I would say, be true to your profession. Be true to your profession in your quest for knowledge and in the desire to excel in your chosen fields. वो field जो भी हो जो आप choose करें, and try to pay back to this great institution what you are taking from it. यहाँ जहाँ हम बैठे हैं मंगूल लॉ, this has been built by a Campbellian as a tribute to this institution. और ये जो किंग एडवर्ड के साथ एसोसिएटेड लेडी रेंटल हॉस्पिटल है और जिसकी हमने बात की कि अप्रूवल हो गया है ऑफ 200 बेडेड हॉस्पिटल, वो मेरे ऊपर एक कर्ज है. सो आई विल ट्राई एंड रीपे दैट इन जब भी ज़िंदगी में मौका मिला. एंड नाउ आई नो कि प्रोफेसर महमूद अयाज का भी उसके साथ एक स्पेशल ताल्लुक़ है, उनके ऊपर भी है वो एक चीज़. So together with all my team, all the professors, the support of my two surgical colleagues, जिन्होंने वादा किया हुआ है, Professor Ibrar Ashraf for the gynae tower and Professor Asghar Naqi. So we will work and inshallah with Allah's help, we will try and achieve this target. So I will end by saying, believe in yourself. Believe in yourself, you are braver than you think, more talented than you know, and capable of more than you imagine. Thank you very much.
Thank you, Madam. King Edward Medical University is going to miss your remarkable achievements and services. I request Professor Dr. Rashid Latif Khan, who is a teacher of all the teachers and needs no introduction, and serving obstetrics and gynecology for more than 5 decades, to share his experiences regarding the maternal mortality and morbidity in Pakistan.
बिस्मिल्लाहिर्रहमानिर्रहीम. प्रोफेसर महमूद रियाज, कह दीजिए मैंने उनका नाम लिया था क्योंकि मौजूद नहीं है. Dr. Faisal Sultan, Dr. Khalid, and all the dignitaries on the stage, and dear colleagues. सबसे पहले तो मैं मुबारकबाद दूँ ऑर्गेनाइजर्स को, ख़ास तौर पर जिन्होंने ये सोचा, महमूद रियाज, मेहरून साहब, आयशा, कि इस तरह की एक कॉन्फ्रेंस की जाए, क्योंकि ये जाना कि ये वो सब्जेक्ट है मैटरनल मोर्टेलिटी जो सिर्फ गायनेकोलॉजिस्ट का वतीरा नहीं है, वही नहीं सॉल्व कर सकते. ये इंटीग्रेटेड अप्रोच जो कॉन्सेप्ट यहाँ पे लॉन्च किया गया वो बड़ा ही इम्पोर्टेंट है, क्योंकि जब पेशेंट मैटरनल मोर्टेलिटी के करीब करीब पहुँचता है आखिर, तो उस वक्त डेस्परेट सिचुएशन में सिर्फ गायनेकोलॉजिस्ट नहीं, एनेस्थेटिस्ट, जनरल सर्जन, हेमाटोलॉजिस्ट, एवरीबडी इज नीडेड, ब्लड ट्रांसफ्यूजन वाले सबकी ज़रूरत होती है. उन सब को मोटिवेट किया जाए टू मेक ए टीम के मैटरनल मोर्टेलिटी को कम किया. हमारा ईमान है कि अल्लाह ताला ने फरमाया कि जिसने एक जान भी बचाई उसने जन्नत में घर बनाया. आई एम श्योर कि आज की इस एक्टिविटी की वजह से, आपके इकट्ठे होके इसको डिलिब्रेट करने से, इंशाल्लाह फ्यूचर में बहुत सारी माएँ बचेगी, और जब उनकी जान बचेगी उसका सवाब ट्रिकल होते होते इन सब तक पहुंचेगा जो यहाँ पे मौजूद हैं. तो आपको इस बात का सवाब मिलेगा जो इस एक्टिविटी के बाद माओं की जानें बचेंगी. तो अब मैं आप सबको मुबारकबाद देता हूँ कि आपने इस तरह से शामिल होकर जन्नत में घर बनाया. एक इजिप्शियन गायनेकोलॉजिस्ट हैं महमूद फता, बड़ा उनका नाम है. उनका काम इस पे बहुत ज़्यादा है, मैटरनल मोर्टेलिटी. जब वो प्रेसिडेंट थे, मैं उनके काउंसिल पे भी था, फीको की. वो बहुत दफ़ा जब तकरीर करने आते आके चुप खड़े हो जाते.
जब स्पीकर चुप करके खड़ा हो जाए तो वो मिनट 2 मिनट भी लंबा अरसा लगता है। उस वक्फे के बाद वो कहते हैं कि यू नो व्हाइल आई वाज स्टैंडिंग हियर सो मैनी यंग लाइव्स हैव बीन लॉस्ट, क्योंकि ऑल ओवर द वर्ल्ड मैटरनल मॉर्टेलिटी गिने तो हर लम्हे कोई ना कोई मॉर्टेलिटी हो रही है। और those who have left this world, or those who are lost, उनकी रूह यहाँ स्पिरिट इस हॉल में घूम रही है और मुझसे पूछ रही है कि उन सब से पूछो कि तुमने हमें तो जाने दिया, लेकिन और इतनी जवान जानने जाने वाली हैं, उनके लिए क्या कर रहे हो आप? सो वही बात है कि वो जवान माँ जो लेबर में या मैटरनल मॉर्टेलिटी की और वजह से यहाँ से रुखसत हो जाती हैं जवानी में ही, और पीछे जैसे कहा गया वो एक माँ के जाने से एक जान नहीं जाती, सारा माशरा डिस्टर्ब हो जाता है, उसके बच्चे, उसकी फैमिली, सब कुछ। आप उसके लिए कुछ कर रहे हैं, ये एक बहुत बड़ा कार्य स्वभाव है। डॉक्टर फैसल ने कहा वी हैव कम लॉन्ग, यस वी हैव, लेकिन वो बात वही है, योर फर्स्ट स्टेप इज फॉर 1000 माइल जर्नी। वो 1000 माइल में हमने अभी 1 मील भी शायद नहीं कवर किया, क्योंकि जहाँ पे बात हो रही है 200 की, 160, 170 की, जो एडवांस कंट्रीज हैं वो तो लेस देन 10 पे खड़े हैं। वी हैव टू कवर लॉन्ग लॉन्ग वे। तो उसके लिए ये सारा काम गवर्नमेंट पे छोड़ देना या किसी और एक एजेंसी पे छोड़ देना, एक स्पेशलिटी पे छोड़ देना, इससे ये मामला हल नहीं होगा, डिज़ायर्ड रिजल्ट्स नहीं आएंगे। तो ये सारे जितने भी यहाँ पे हैं, ये तो टर्शरी केयर में इंटेग्रेटेड अप्रोच के बड़ी अच्छी बात हुई, लेकिन वहाँ से किसी साहब ने कहा था 3 Ds 3 डिलेज। तो वो डिले जो नंबर 1 है डिसीजन मेकिंग की, वी हैव टू क्रिएट अवेयरनेस एट दैट लेवल, एट द फैमिली लेवल, और फिर वो सारे जितनी भी बातें हैं सोशल, तो द होल नेशन हैज़ टू बी मोटिवेटेड। उसके लिए हमें मीडिया की सपोर्ट चाहिए, हमें प्रिंट मीडिया की सपोर्ट चाहिए, इलेक्ट्रॉनिक की चाहिए। वो जगह जगह मैसेज पहुंचाया जाए कि ये जवान माएँ बचाई जा सकती हैं, वक्त पे पहुंचाई जाए वहाँ। ये सारी बातें सब ने कही, मैंने भी दोहरा दी, लेकिन जस्ट कमिंग बैक टू लेडी एचिसन, एक ज़माना था जब हम सब स्टूडेंट थे, लेडी एचिसन उस वक्त टीचिंग स्टाफ नहीं था, अटैच था, लेकिन वहाँ प्रोफेसर साहब नहीं होते थे। जो पहली प्रोफेसर वहाँ पे अपॉइंट हुई वो डॉक्टर इकबाल रशीद मियाँ थी। मैंने उनके साथ काम किया हुआ था, आई वॉज हर असिस्टेंट। तो मैं मुल्तान से लाहौर आया तो मैंने डॉक्टर साहब से पूछा कि लेडी एचिसन कैसा है? कहेंगे ठीक है, बड़ा अच्छा है, कन्वीनियंट है, वगैरह। मैं कहा डॉक्टर साहब सुना वहाँ तो एनेस्थेटिस्ट ही नहीं होता, परिषद तक के साथ वहाँ तो एनेस्थेटिस्ट ही नहीं होता। कहती हाँ नहीं है हमारे पास एनेस्थीसिया। तो मैंने कहा फिर आप कैसे मैनेज करते हैं पेशेंट को? वो कहती हैं हमारे पास 3 तरह का एनेस्थीसिया है, लोकल, वोकल एंड फोकल। मैंने कहा ये लोकल, वोकल और फोकल ये क्या होता है? कह रही लोकल तो तुम समझते हो कि लोकल लगा के हम मैनेज करते हैं, बट लोकल डजंट वर्क ऑलवेज। और जब वहाँ पे लोकल से काम ना चले, फिर हम वोकल, हम कहते हैं चीख ना मारी, तेरे रिश्तेदार बाहर खड़े नहीं, वो सुन लेंगे, चुप चुप चुप। तो वो वोकल हो गया। मैं क्या फिर फोकल क्या होता है मैडम? कहने लगी जब उस पे भी वो चुप ना करे, चीख मारे, एक जन्नाटेदार थप्पड़ मारते हैं उसके मुंह पे, वो स्टन हो जाती है और फिर हम डीएनसी कर देते हैं। तो ये लेडी एचिसन की हिस्ट्री है, कोई पुराने ज़माने का नहीं सुना रहा, मैं सुना रहा हूँ। So Lady Aitchison has come long, long way. Now it's a proper teaching hospital. So we have made progress. We have definitely made progress. इसमें जो पॉजिटिव बातें हैं वो भी करनी ही चाहिए, वो भी करना चाहिए। पाकिस्तान में बहुत कुछ अच्छा हुआ है, उसको भी देखना चाहिए। और इसी तरह अगर ये फिगर्स 200 से 170 आना साउंड्स के बहुत कुछ और है, लेकिन जो ये 30 का गैप भी आया है, इसमें भी बहुत इनपुट हुआ है। उसमें हम सब शामिल हैं, सारी सोसाइटी शामिल है, डॉक्टर्स ऑफ कोर्स एंड अमंग्स डॉक्टर्स स्पेशलिस्ट, ये सब उनका करना है। तो इसलिए हम अप्रिशिएट भी करते हैं कि नर्सेज, मिडवाइफ्स, डॉक्टर्स, दे हैव मेड देयर इनपुट एंड मेड सम इम्प्रूवमेंट, बट स्टिल देयर इज लॉन्ग डिस्टेंस स्टिल टू कवर। अगली बात, हम बातें बहुत करना ठीक है, कम अज कम। जब से हमें थोड़ी सी ये लिबर्टी मिली है ना कि उर्दू में भी बोल लो, पंजाबी में भी बोल लो, अंग्रेजी में भी बोल लो, लोग यहाँ खड़े होकर बहुत ही बोलने लगे। मेरे जैसे को माइक मिल जाए उतरने को दिल ही नहीं करता। बातें बातें बातें, बातों से बात नहीं बनती। हम सबको जहाँ जहाँ भी हम हैं, अपने स्फीयर में, अपने इर्द गिर्द के लोगों पे वी शुड वर्क ऑन इट। ये जो डिलेज की बात हो रही है, सबसे पहले आपके रिश्तेदार गांव में रहते हैं, आपके रिश्तेदार, ये वार्ड सिटी जो है, सबसे ज़्यादा तो काम वहाँ करने वाला है। अभी भी 80% डिलीवरीज वहाँ वार्ड सिटी के अंदर होती हैं। लेडी ब्लिंडन भी है, लेडी एचिसन भी है, और बहुत सारे प्राइवेट हॉस्पिटल, वहाँ नहीं आते मरीज। तो इसलिए हमें ऑन द ग्राउंड एक्टिविटी करनी चाहिए, हर एक को अपने दें जितना भी आप कर सकें। और अगर आप इस तरह से करें, जैसे शमसा ने कहा कि मैं हमेशा कहता हूँ कि पाकिस्तान में स्किल्ड बर्थ अटेंडेंट अगर हर जगह हो जाए तो मैटरनल मोर्टेलिटी बहुत नीचे आ जाएगी। तकरीबन आबादी के हिसाब से 50,000 स्किल्ड बर्थ अटेंडेंट्स की ज़रूरत है। हम 5,000 क्वालिफाइड गायनेकोलॉजिस्ट हैं पाकिस्तान में। अगर हर कोई अपने तौर 10 TBAs को कर दे टू बिकम स्किल्ड बर्थ अटेंडेंट, मैटरनल मोर्टेलिटी बहुत पीछे आ जाएगी। और हम कोई इतना सा बीड़ा उठा लें कि हमने 10 को ट्रेन करना है, कोई मुश्किल काम नहीं है। कोई 1 साल नहीं, 2 साल में कर लीजिए, 3 साल में कर लीजिए, क्योंकि ये मैटरनल मोर्टेलिटी तो बहुत एक लंबा। तो इसलिए मेरी रिक्वेस्ट होगी, हम सब जहाँ पे जाएं, ये जो आज इन्होंने शुरुआत की है इंटीग्रेटेड अप्रोच, इंटीग्रेटेड इज नॉट ओनली अमंग्स द स्पेशलिस्ट, gynecologists, surgeon, anesthetists, and blood transfusion, things like that. It is integrated in the whole society. Whole society. Every member of the society should focus on it, concentrate, and propagate. आखिर में मैं फिर आप सबका शुक्रिया अदा करता हूँ कि आपने मुझे यहाँ बुलाया, इतनी मुझे इज्जत दी। मैं तो किंग एड में दाखिल भी ना हो सका, मैं निश्चित चला गया, मेरा मेरिट ही नहीं था। अब अल्लाह ताला की देन, आप लोगों की मेहरबानी, मैं यहाँ खड़ा तकरीर कर रहा हूँ। थैंक यू।
थैंक यू सर फॉर योर इंस्पिरेशनल टॉक। आपने बहुत ही खूबसूरत बात की कि अगर एक बंदा 10 लोगों को ट्रेन कर दे तो वो लाखों को बचा सकता है। और नाउ आई वांट टू रिक्वेस्ट वर्दी वाइस चांसलर डॉक्टर महमूद इयाज and on all the honorable guests and the Dr. Rashid Latif Khan to kindly come forward for shield distribution.
I think first of all we would like to honor Professor Aisha, and I would request all Professor Rubina, Professor Uzma, Professor Ibrar, and everybody to be on the stage, because this is a great occasion for us, because she has provided us a long time and a lifetime services to this institution, and इनकी services यहाँ पे बेतहाशा हैं, and we're extremely indebted the way she led in the academics and the administration and everything. So I think this is a great occasion for us. Remember, she's not retiring. She is actually, and we are not giving. This is not a farewell. We're just honoring her today at this event. Farewell तो उनकी अभी हमने रखी हुई है, बहुत हम करेंगे जिसे हमने करनी है, लेकिन आज we are going to just honor her with a shield. So I think जी हाँ बुलाएं ना सारों को.
Professor Dr. Kiran Khurshid, Professor Dr. Amna, kindly join us on the stage. Dr. Sabahat, MS Lady Wellington, kindly join us on the stage. Professor Dr. Asghar Naqvi, sir, kindly join us on the stage for the shield distribution. Professor. Now I request Professor Dr. Mahmood Iyaz and Professor Dr. Rashid Latif Khan to kindly present the shield to Professor Dr. Aisha Malik. I request Professor Dr. Rashid. I request Professor Dr. Mahmood Iyaz to kindly present the shield to the chief guest of the ceremony, Professor Dr. Rashid Latif Khan. I request Professor Dr. Mahmood Iyaz and Professor Dr. Rashid Latif Khan to present the shield to Professor Dr. Khalid Masood Gondal. कुछ नहीं आ रहा ना, मैं एक मिनट माइक इधर दे। हाँ जी, मुझे भी अब किसकी होनी मुझे बताती जाओ, किसकी है मुझे बताओ, बताते जाओ। वीसी को दिलवाएं। अब ये किसकी हो रही है शील्ड, किसकी हुई है? अच्छा, वीसी साहब को दिलवाना है हमने। अब वीसी साहब की शील्ड मंगा लो। वीसी साहब की शील्ड दो जी। अरे चल मुझे माइक तो I request Dr. Rashid Latif Khan Sahab to present the shield to Professor Dr. Mahmood Iyaz.
क्या हालात है?
I request Professor Dr. Mahmood Iyaz to present the shield to Professor Dr. Amir Zaman. I request to present the shield to Professor Dr. Farooq Afzal, Principal SIMS. I request Professor Mahmood Iyaz and Professor Dr. Rashid Latif Khan Sahab to present the sheet to the speakers of today's session, Professor Dr. Asghar Naqvi. Professor Dr. Faisal Sultan. Professor Dr. Asghar Naqvi. Professor Dr. Mahmood Iyaz and Dr. Rashid Latif Khan to present the sheet to the Chief Organizer of today's conference, Professor Dr. Mahmood Iyaz. I request Professor Dr. Mahmood Iyaz and Dr. Rashid Latif Khan to present the sheet to Professor Dr. Meena Sohail. Professor Dr. Muhammad Tayyib. Professor Dr. Muhammad Tayyib. Professor Dr. Usman Hussain. Professor Dr. Ibrar Ashraf. Professor Dr. Farah Yusuf. Professor Dr. Kiran Khurshid. Professor Dr. Saira Afzal. Professor Dr. Shamila Ijaz. Professor Dr. Amna Zia. Dr. Abda Sajid. Dr. Farhana.
This is very good. और आपको पता है जो